this computer. All right. So it is, what is today? Today is the 10th. Yeah. So June 10th in 2022, I'm pretty sure. And I said today we're going to talk about pharmacology. So I have some slides put together. Tomorrow's your birthday. You're going to be 21 finally? That's what I thought.
37.
Yeah, tomorrow's not my birthday. But happy birthday just the same. You actually, one of the students from the new cohort's birthday is tomorrow as well. And he turns 20, if that makes you feel any better. I was like, oh God, I have like coffee cups older than him. So it's happy birthday. That should be a good time. So we're going to talk about pharmacology today, and I kind of put together a PowerPoint rather than a question and answer session today. And we're going to talk about some specific things about pharmacology and what you need to worry about, what you don't need to worry about. Some of it is borrowed from my other lecture, but then we're also going to talk about what we need to look for when it comes to pharmacology. So let me get it brought up here. All right, so I got that brought up. Let me bring up the chat just in case anyone says anything. Chat. And where is, there we go, participants. All right, so I got everything brought up now. I really wish, like, and I've sent this into Zoom like 1,000 times. I wish Zoom would just remember my settings so that if I bring something up, it just stays the way it was. I don't want to have to constantly reschedule and resize and all that fun stuff. But anyway, it's a minor break. All right, so pharmacology. How many of you guys have started encountering some of the questions on that? Have you guys started seeing some of those? Okay. How many freak out every time you get a pharmacology question? A little bit, yeah. So some ideas and some specifics about pharmacology. One of the things you have to remember about pharmacology is it's not always necessary, and I haven't seen the questions from PTA final exam on those. But as far as the boards go, and this is coming from somebody who helped write some of the pharmacology questions, the boards don't need you specifically to know the difference between a one specific alpha blocker versus another specific alpha blocker, kind of trying to understand what the difference is between two different alpha blockers. The main idea of pharmacology for the boards is looking at what is that drug going to do to that patient and what do you have to be worried about, right? You know, for example, looking at most of the neurological based meds, what's one of the side effects of almost all the neurological meds? Puts people to sleep, right? Think about almost all the meds that are out there. Almost all of them put people to sleep in some way, groggy, dizziness. And so that becomes a safety concern. You know, getting a patient up who's on heavy narcoleptics is going to be a fun time. So most of it is dealing with safety in general, right? Now, I'm going to review the terminology that I reviewed at the end of last semester as well, just because you do have to know certain terminology. And I picked out the words you do have to know for terminology, and we're going to review that now. And then we'll kind of go through the classes of meds. So some of the key terms you have to understand, obviously pharmacology is the study of drugs, right? Any ology is study of. So biology, you know, Mr. McKeever-ology would be the study of me. I don't know who would want to do that. That's a scary study. And then we have pharmacokinetics, and I'll make this PowerPoint available to you guys. Don't worry. I just kind of doctored it up a little bit ago. The pharmacokinetics is the absorption of the drugs, right? It's what happens when you take the drug, and once it passes whatever route it goes in, what happens to it, right? So for the most part, which is the most common way for us to take drugs?
Orally.
Yeah, orally, right? So we pop a pill and it goes down, right? I just took my allergy med a little bit ago. So the pharmacokinetics of my allergy, and I need it, you can hear. Pharmacokinetics of the allergy pill would be, how does it go down to my stomach? How does it get dissolved? How does it get absorbed into the bloodstream? Where does it get distributed to? And then what happens to it after that? How does it get out of my system and how does it get excreted? That's the pharmacokinetics part of it. The pharmacodynamic part of it is, what does it do to my body? So I'm going to use my allergy med as an example, right? So the allergy med themselves, so the pharmacodynamics is going to be both the positive and the negative effects of the drug, right? So my allergy med should do what to me? Positively, hopefully. Because I'm on Claritin D. So what should it do for me, hopefully?
Like suppress your allergens.
Good. Suppress the allergen effects, right? So suppress my enes, the histamines, cytokines, and all those fun things. And hopefully reduce my symptoms caused by those enes, right? Those inflammatory mediators. You know, in my case, the main thing I wanted to do is make me be able to breathe again. That would be really nice. Now I'm on Claritin D, which also has that fun medication, which is that strong decongestant. What's that strong decongestant that you have to get over the counter?
Sudafed.
Yeah, pseudoephedrine. Yes, right. Because we had dealers that decided to make methamphetamines out of it, right? And so that has a secondary side effect because basically my drug has two drugs in one. But again, it's going to look at how that affects my body. And pseudoephedrine has its own pharmacodynamics and the way it works in the body, right? Some people it makes wired, some people it makes sleepy. And then it's also going to look at what the side effects are of that, the dynamics would look at that as well. So those anti-allergy meds obviously are going to slowly kick down my immune system as well slightly, right? Because if it affects my mediators, it's going to affect my immune system slightly. Now, most allergy pills don't have that huge of effect as like an immunosuppressant, but it does affect my immune system slightly. It's also going to have some other side effects. Like for most people, when you take an allergy pill, it might make you sleepy, especially like Benadryl, right? Okay, you're moving. I just make sure I didn't freeze. Sorry. And then we have the pharmaceutic effect, which goes into the pharmacokinetics, and it's how this drug broken down, right? So part of the pharmacokinetics is the pharmaceutic. That means if I take the pills are designed a specific way. Have any of you ever gotten an ER pill from the doctor? Pill that at the end it says ER. Does anyone know what that ER stands for?
Extended release.
Extended release, right? Yeah. So they design the pill such that the coating on the pill takes a while to dissolve as it's going through your intestines. That allows that drug to slowly be excreted through your body rather than just rapidly one hit. Now, would that be beneficial for like pain meds?
That's what made Oxycontin so safe, less than 1% addictive at first.
Right, exactly, because it was an extended release drug. You couldn't break that coating on it, right? Not just by putting it in water and watching it dissolve. Right, yes, exactly. So we had those extended release drugs help us long-term. Most of your allergy meds now are almost all extended release drugs because they say they work for 12 hours, 24 hours, whatever it is. They never do they? They just say that. Right, you get about 10 hours into your drug, you're like, oh, I can't breathe again. So yes, so the pharmaceutic goes into the pharmacokinetics. Then the pharmacotherapeutics is the use of drugs to treat diseases. And the reason we have to separate that out is because even though back in that last slide where we're talking about the pharmacodynamics and all that fun stuff, the pharmaceutics, stuff like that, we still look at drugs that aren't used to treat drugs. We still need to look at heroin. We still need to look at methamphetamines. We still need to look at all that to see how it affects the body. The pharmacotherapeutics says, well, how can we use those drugs to treat whatever? We use a great example of this right now that's happening in a lot of states. There's a plant that comes from Southeast Asia called Mitragyia speciosa. It's the colloquial term is kratom for it. In Southeast Asia, they've been using this drug for a while to treat pain. And it's not a drug, it's plant, but almost all drugs come from plants, right? It has a great effect that it acts on the mu opioid receptors just like an opiate, but guess what? It doesn't have the addictive effects, right? And the other thing it does is you can't overdose on it because it has a certain alkaloid in it that if you take too much of it, you throw up. So it has no way to really be overdosed And it's been used recreationally by people for a while, but there's a lot of doctors that are now kind of recommending patients take it that are in chronic pain and stuff like that. There are a few types. Yep, absolutely. Yeah, I could go in for hours about this because this is one of the ones I've researched a lot. It has in certain doses, it's energy. In high doses, it causes sleep. In certain ones, it affects their mood. So there's definitely some, because it's just like any other plant. There's multiple strains of plants out there, right? You look at cacti, and they're like 9,000 different cacti. Trust me, I've had the lessons on the cacti in our backyard. Just I don't need to know them anyway. So we have this thing, and suddenly somebody said, "Well, hey, why don't we look into the pharmacotherapeutics of kratom?" And why would they be interested in looking at the pharmacotherapeutics of it? Because they want to do what?
Make money.
Make money. There you go. That's all there is to it, right? And so now magically what you're finding is all over the country, there's all of these drug enforcement agencies in each of the states suddenly going, maybe we need to ban this drug because, it's bad. And then you look at who's promoting the bills to ban the drug, and it's Merck Medco. Because if the drug gets banned from consumer purchase, well, then they can patent a over-the-counter pill that you have to buy from the doctor, right? So yeah, anyway. So we do look at the pharmacotherapeutics of pretty much stuff that we do. Penicillin's a great example of it, right? Who'd have thought that a mold would get rid of most of the bacteria, right? That's what penicillin is. And then kind of going on lines there again, pharmacoeconomics, comparing one drug price to another. Do you all look at your drug prices when you pick up your drugs? Are any of you on maintenance drugs? Because I am, and I'm constantly checking, because the pharmacoeconomics, your drug can vary not only from brand name to generic, but from pharmacy to pharmacy. It's kind of crazy that, I know one of the drugs I'm on, if I go to Walmart, that drug is $140. But if I go to Walgreens, the drug is $18. And that's a huge difference. And now the average consumer doesn't really spend that much time. The average consumer goes to one pharmacy for pretty much their whole life, just because they know that pharmacist, they trust that pharmacist. But yeah. And then we have the pharmacogenomics, right? So if Jason and I take the same med, we're both going to react differently to it. And the reason is our genes, right? Whether I'm wearing blue ones or he's wearing brown ones. I'm just joking, wrong genes. So our genes are going to affect the way drugs affect us. I have a really, really good friend who's, well, I don't say really good friend, but a friend who, when he takes Tylenol, falls asleep. And he swears to God, and I think some of it's psychosomatic, but that's beside the point. But he swears any type of medication he takes, he just falls straight asleep. Oh, I take Advil, I fall asleep. I'm like, well, maybe you should get more sleep. That's beside the point. So pharmacogenetics affects all of us a little bit. Genomics affects all of us a little differently. And again, my favorite one is the psychopharmacology. There's actually degrees coming out now in psychopharmacology. It's how the drugs affect our brains. And we're finding out a lot of the drugs that are out there affect our brains differently, right? We didn't really look into that until we started getting the addiction problem going on. Sorry, my caffeine. All right, so then we get into dose and dosage, right? And the way I always remember this, right, is dose is just taking once, right? If you're talking about an age, you're talking about a period of time. So dose age is the whole period of time you're taking the drug. Does that make sense? So dose, I take my pill, right? So let's say you get a strained vac and the doctor prescribes 800 milligram ibuprofen to you. He's going to prescribe 800 milligrams ibuprofen once every 4 hours for 10 days. The dose is going to be that 800 milligrams. The dosage is going to be the total amount that you're going to take over that 10 days. So, 4 times a day, 800 milligrams, whatever it may be to get there. The next 3 terms, you do have to know, like I mentioned this when we talked about this in class, but misfeasance, malfeasance, and nonfeasance, there have been more questions popping up about these. And it's mainly because of the legal effects of them, right? Misfeasance, administration of the wrong drug or dose to a patient that results in harm or death. So an example of this would be maybe the nurse comes in to give a patient their pain meds. And they're supposed to get one pain med, but for whatever reason, the nurse gives them 4. That would be a misfeasance case, especially if the patient suffered a negative effect from it. Malfeasance is where the drug is given to the patient, and typically malfeasance has to do with death, but it's when they're given the correct patient to the drug and they die, it's usually because you gave them the wrong route. So they either give them a suspension drug orally, or they'll give them a oral drug that should have been injected or something to that effect. And the big one that's been in the news lately has been nonfeasance. There's been quite a few cases showing up on, especially in the American Medical Journal and stuff like that, that show that nonfeasance is on the rise. And nonfeasance is withholding medication, right? That leads to harm or death. Why would somebody withhold medication from a patient? What do you guys think?
Would it be because they're worried about abuse of the drug?
Could be, maybe the nurse is like, yeah, I'm afraid you're gonna abuse the drug, right? Alex brings up a good point. The patient was just rude, and so we're gonna punish them by not giving them their meds, right? What do you think, Jason?
I've seen nurses not administer medications because they were just too busy.
That could be too. Yeah, exactly. There's a kind of the third reason, right? Their status may think they're just gonna die. Yeah, right. So there's all kinds of reasons why we might withhold a drug. But withholding that drug when it's prescribed is considered a nonfeasance issue, and that you can be sued for. Most medical practitioners have a certain amount of qualified immunity. And what that means is if something bad happens, as long as you were doing healthcare for that patient, you have a certain amount of immunity saying, hey, yeah, something bad happened to this patient, but it was in it happened while in the care of a patient, right? So let's say you go and you give a patient CPR, but you break their ribs. You're protected under the Safety Act at that point because they say you were there to save the patient, right? So the patient can't sue you for that. In this case, if somebody holds back the meds for a patient, they lose that qualified immunity and they can be sued for that. Because the patient was prescribed that medication, they should have been given that medication. In most cases, like Alex said, I've seen it because the nurse is just punishing the patient for something they did. Like they pooped their pants. And so the nurse is like, well, I'm not going to give you your pain meds now. And it's wrong, right? There's no ifs, ands, or buts about it, right? It's wrong when they do that. But it happens. It happens way too frequently. And I'll say in this valley, I've seen it way more than I've seen it anywhere else, especially in some of the nursing homes around the valley. They'll just hold patients' meds until the patient either begs or does something nice for them, right? There was a case a few years ago, I want to say it was in Phoenix, but don't quote me on that, where they found that a nurse was withholding meds unless the patient's family gave her money. Yeah, like that's just wrong. That's a pure nonfeasance case. And that nurse ended up with all kinds of bad things happening to her. So when we talk about meds, most of the time, we're going to see one of the 3 terms when we talk about the med, either the chemical name, generic name, or the brand name. The good news for your boards, you're only ever going to see the generic or the brand names. You're not going to see the chemical name. Because that chemical name, you have no idea what N-acetyl paramethylphenol, whatever that says, right? I can't even say the word. If you saw that, you would have no idea that's Tylenol. I mean, I may from going Paramino, I know that's kind of Tylenol. But most of us know Tylenol is Tylenol, right? That's kind of like Velcro. You didn't realize that most of the stuff that you have that's Velcro isn't Velcro. I don't know if you know that, because Velcro is a brand name. It's usually hook and latch, like I'm pretty sure. Yeah, right? So I got these cable ties here. They're really stuck together. Right? These cable ties that I can wrap around cables that are Velcro. I call them Velcro because that's a colloquial name for them, right? But in essence, it's actually hook and latch is the technical term for it. Tylenol is the same way. We always pick Tylenol up at the store, but it's very rarely that we buy Tylenol anymore. We usually buy generic Tylenol. And what that is acetaminophen or paracetamol. And paracetamol you only see if you're in England. I don't know why they call it paracetamol over there, but that's the big term in England. I think they just wanted to get away from us. Or APAP is the other term you see a lot. And that comes from the chemical name, right? So your boards may ask you a question about a statin, right? What's a statin do?
Isn't it for cholesterol?
Okay, good, right? They may give you a question about a statin. That would be talking about the generic name, right? Or they may ask you about Lipitor, right? And Lipitor is a specific statin. So they're only going to ask you, yeah, Brooke, and it does cause some muscle weakness at rest. Yep, good. Yeah, like Xerox, exactly. I didn't see that message up there. Exactly, right? We're going to go make Xeroxes. We don't say that anymore as much anymore, do we, though? Because Xerox has kind of gone by the wayside. But, God, I remember saying that, actually, now that you mentioned that. I'm old. But, yeah, so when we talk about these drugs, the good news is when we're talking about the main brand name drugs, they're going to be the big ones. They're not going to be, like an obscure brand name drug, like one of the new drugs that's out there. I can't even think of, let me think of some of, I don't know, one of the ones that's just been advertised on TV. There's not going to be a board question about that. When they ask you about a brand name drug, it's going to be a common one. One of the ones you may see a lot is Soma. Right? Have you guys heard of Soma before? What's Soma?
Muscle relaxer, right?
Right. Yes. And that's the brand name, right? The generic name, it has different, but it is in classification, a muscle relaxer. Everyone knows Soma or should know Soma because old people ask for it by name. It's their preferred drug of choice, right? It is a really kind of potent muscle relaxer. But then there's another muscle relaxer called Scalaxin, which works very similar to Soma, but that's not a very common one. So there's not going to be a question on Scalaxin on your board. Does that make sense? Yes, Soma, S-O-M-A, you got it. And we're going to kind of talk about some of the big ones when we go through the specific drugs. But like I said, they'll ask you about Soma, but they won't ask you about Scalaxin because Scalaxin is one of the obscure ones. And actually Scalaxin's older, but we just stopped using it because Soma is so much better. It's newer, that's all it is. So the drug class is the main thing you need to worry about for your boards. What does the drug do, right? For example, Tylenol is a non-steroidal anti-inflammatory analgesic. Right, or non-NSAID, so it's a non-NSAID analgesic. It relieves pain. This would be your muscle relaxers, your antispasticity meds, your heart meds. Those would be that drug class. And then also you may find there may be questions on the boards about whether a drug is prescribed or if it's over the counter. And the big question I've been kind of hearing about lately for this is, which classification of drugs can we recommend to the patient? Prescribed drugs or over-the-counter drugs?
None.
Yes, there you go. Neither. Right? Yeah, Brooke saw shaking her head, right? None of those. But that could be a trick question because we think about over-the-counter and we kind of think we think over-the-counter is safe almost, right? Even though those drugs are just as potent. So we have to be careful that, we don't necessarily talk about drugs. Now, do we have to know about their drugs? Absolutely, right? We have to know what drugs they are on. But even myself, who's studied drugs at this point pretty extensively, I don't know all the drugs. They're just constantly changing. They change names and they add one chemical compound so it can be a new drug, and I have no idea what it is. So I kind of have to keep a little bit of a desk reference with me when I'm looking at drugs. And then the fun one is compounding pharmacies. We've got a couple of those in the Valley. The compounding pharmacies are kind of boutiques. These pharmacies make specific drugs. So let's say that Tylenol, for whatever reason, you react really poorly to because of the mixers that are in Tylenol. But you need the paracetamol from Tylenol to help with pain. Well, a compounding pharmacy can make you a very specific pill that maybe doesn't include all the fillers that Tylenol includes. And they might use a different filler that you're not allergic to or you don't react to. And there's a lot of money in compounding pharmacies. That's all I'm going to say is if you have a compounding pharmacy, you can make a lot of money because those are really boutique pills. Most of your drugs for your pets come from compounding pharmacies. So there's that. So when you're looking at pharmaceuticals, right, we have to look at the effects, right? The physiological effects specifically to the desired drugs, right? We also have to look at all the drugs have desirable and undesirable effects, right? Desirable would be treating the condition that it needs. Hey, there's Anthony. Look at him. He's got his whole streaming setup there going. He's professional. It's nice to see him. He's looking fresh there. I'm telling you, nice cut. And so all the drugs have a desirable effect. So let's say that you're taking a heart med that's job is to slow your heart rate. That would be the desirable effect, right? Slowing down your heart rate. What would be the undesirable effect for something like that?
It's usually diarrhea and death.
Yeah, diarrhea and death is pretty much every drug's undesirable. Yes, may cause death, right? Those are the ultimate ones, right? Fatigue, yeah, exactly, Brooke. Because if your heart slows down, that means that your overall effect of your heart's going to slow down as well, right? As the heart rate slows down, what's the body going to do to the blood pressure to fight the change? To make sure there's the same amount of blood available.
Going to increase it?
Yeah, it's going to increase the blood pressure, right? What you usually see is blood pressure meds that lower your blood pressure increase the workload of your heart, or the ones that lower the workload of your heart increase your blood pressure. So they kind of work opposite each other. So if the heart starts slowing down, the body's going to increase the squeeze of those arteries to get the blood out to areas that the heart's slowing down for, right? So it's going to increase that circulatory blood pressure. So we have those undesirable effects of now having the high blood pressure associated with those meds. So those are the kind of things that we kind of pay attention to with the drugs, right? Those are those adverse reactions, the stuff that we don't necessarily want to happen. Now, all drugs have minor adverse reactions. Tramadol is a drug that I think of a lot that's given to patients. Tramadol is a pain med. One of the major side effects of Tramadol is itchiness. And I'm talking like feeling like you have bugs crawling on you, itchiness. Right. So they're like crawling up your skin. You have these little mites that are going all along your skin that are making you trying to get you all itchy. Is it working? And nausea is another one. Yeah, Diana. Nausea is another one that's kind of out there, right? A lot of people get nausea from every drug, even from Advil. I know some people that if they take Advil on an empty stomach, they get nausea. So nausea is a big one that happens a lot. And then the other one of a lot of our meds is either diarrhea or the opposite of diarrhea, constipation. One of those two happens, and then death. So you're going to die from diarrhea and constipation. Each drug, though, is going to have a specific condition it treats, but we often find that drugs then have secondary conditions they treat, right? There was this wonderful drug a long time ago that was used to treat heart problems when your patients in congestive heart failure. And what they found is that drug increased circulation throughout the body. And the side effect they found out this drug was giving was it gave men random erections. And so this heart med went from being a heart med to being Viagra, right? And so so that's why if you ever see it like ads for Viagra or Cialis, they talk about taking your blood pressure medications with it, because you can have really bad effects by taking those drugs together. So yeah. We often find things like that as we're going through these drugs. Dependence and addiction. Remember that all addicts are dependent on their drugs, but not all dependent people are addicts, right? What's the difference? Well, we have the tolerance level. Tolerance level is how much we can kind of fight the drug. And as we take a drug, what happens to our tolerance levels?
Get higher and higher.
Yeah, it goes the other way. It gets higher, right? It just keeps taking more and more for it, right? So say you're a person that regularly takes 2 Advil in the morning, and you take that just every day because I don't know why, but you do. And then you get a headache later in the day. When you take 2 more Advil, it's less likely those Advil will work because you've already kind of built up a tolerance to that drug, right? So then you're like, well, I'll take 4 Advil. Well, now we're starting to get into some really problematic areas because you're starting to get to those levels of Advil that are bad for you. So the tolerance kind of happens. I've seen a couple questions on tachyphylaxis, so I mentioned that in here. Tachyphylaxis is this weird, rapid tolerance to a drug. So the patient takes a drug for the first time and they already are tolerant to it. And we don't know enough about it yet why it happens, but it happens to pain meds a lot. And sometimes it might be because maybe the patient was an addict before and now we're no longer an addict, and they give them a small dose of oxy or something like that. It works the very first treatment, the next treatment it stops working. They've developed a tolerance to it. So dependence means you need the drug to function, either mentally or physically. So I'm going to use my own example right now, taking my allergy med. I need my allergy med to function. I am slightly dependent on that drug to have normal sinus function, right? But am I addicted to that allergy med? I don't have mental cravings for the drug. That would be really weird, first of all, right? Addiction usually have physical and mental cravings for that drug. And you go out of your way to fulfill those mental cravings. Opiates are a great example of that, right? Opiates, that craving effect really kicks in with those patients. And they start just seeking out the drug. And then they end up not being able to get the drug, so they go to illicit methods to get the drug. Last I saw, I was reading something about it in the Valley here. If you just want to get like a basic level hydrocodone, it's like $25 for one of those pills on the black market, like on the street. You need to get them, right? That's expensive. It's the easy way to make money, but it's expensive. I did not say that. That was a joke. Don't censor me, YouTube. So not all dependents are addicts, but all addicts are dependent. Will you have some patients that are both? What do you guys think? Do you think you'll encounter patients that are both dependent and addicts probably at some point in your career? Yeah. Yeah, it's going to happen. You're going to run into addicts. And you'll know an addict versus somebody that's dependent. The dependent person will say something like, oh man, I forgot to take my meds today and I can feel it. That's kind of how you know that patient is dependent on that med, right? Whereas the addict is going to definitely have those addiction type behaviors, right? When we did ER or ED screens back in Pennsylvania, you would go down there and you go in to screen them as PTA, and they'd be like, man, can you get me XYZ pill? And usually when they ask you that, they know like the specific dosage too. That's how good they are. They're like, I need the 10-250 Vicodins. And I'm like, I don't even know what a 10-250 Vicodin is. And here these people are specifically asking for it, right? That's how you know an addict, right? They know what they want. All right, so let's talk about neuromuscular pharmacology first. And I want to get into the right chapter for this.
Mr. McKeever, I have a quick question.
Yep, go ahead.
So you said that you're going to make this PowerPoint available to us. Where would we find it?
I'll put it on the YouTube channel. I'll put a link to the Google Drive link up for it.
Okay.
That way you can just download it straight. All right, so let me find, yeah, there we go. So let's talk neuromuscular meds. The main groupings that you're going to encounter in neuromuscular pharmacology are anti-epileptics, antispasmeds, your dopamine meds, and your muscle relaxers. The two that people get confused about the most are the difference between an antispastic and a muscle relaxer, because they look a lot alike, right? The main idea to understand is the antispastic med, the way I think of it is the antispastic med works more at the PNS level, where the muscle relaxer works more at the CNS level. Does that make sense? Because the antispastic is going to work out at the muscle that's causing the problem. Whereas the muscle relaxer is going to relax all of your muscles. And you're going to be jelly, right? Does that make sense between the two, though? Kind of clarifying it, right? So when we talk about these meds, right? Let's talk first about anti-epileptics. What are those going to do?
Prevent seizures.
Good. They're going to prevent seizures. That's the main goal of it, right? And it can prevent any of the seizures. It could prevent the grand mals, the petite mals, the absent seizures, whatever it may be. The downside to most of those meds is a lot of effects in the actual CNS, right? Because that's where it's acting. The main thing I've seen with most anti-epileptics is it starts affecting the cerebellum, right? So if it affects the cerebellum, what are you going to see?
Balance issues.
Good, balance issues, right? What else? Are you going to see apraxia or ataxia?
Ataxia.
Yeah, you'll see ataxia. Good, right? Because remember, apraxia cerebrum, the processing, right? Plan. So yeah, you're going to see some ataxic issues. You're going to see some balance issues. Sometimes some behavioral issues. Most of these drugs will have gastrointestinal issues. Like I think somebody mentioned that before, right? Almost all of them makes you nauseated. But in general, is that something we're going to be worried about? Not necessarily. We just kind of have to, if we go in the patient's nauseated, have to say, yeah, I understand. Kind of all drugs make you nauseated. What's some of the best methods to get over nausea? Get up and moving. Because think about it, if you're laying down and you're nauseated, your belly's just kind of sitting there. That means that drug is just sitting in that one part of your belly, right? And if it's just sitting there, it's going to get, at least if you get up and moving, you get your, your system going. And so you can process that drug out a little bit faster. If a drug works on the CNS, then most commonly, it's also going to possibly give you a headache. And that kind of makes sense, right? If it's going up to the brain, it's probably going to give you a little bit of a headache. And that's another side effect of those anti-epileptics. But if you ask somebody that's got epilepsy, would you rather have your seizures or would you rather have a little bit of headache? Most of them are going to say, I'd rather have a headache, right? Because seizures are no fun. They're no bueno. So the main thing, if it's talking about these meds, the main one that your boards will ask you about is Dilantin. This Dilantin is one of the most common ones. So if it says your patient, and for the anti-epileptics, what I see is it'll say your patient is on Dilantin. What safety precautions or what concerns would you have with this patient? And it would be monitoring them for seizure activity because you know that they're an epileptic drug. It may talk about ataxia as well, but the main idea for anti-epileptics, to ask you a question, is monitoring for seizure activity. So what do we do if somebody has a seizure? What's our procedure if somebody's having a seizure?
Do you lay them on their side and just kind of guard, like watch them?
Yeah, lay them on the side, clear the area, and that's it, right? We used to put a spoon in their mouth, put a wooden spoon in their mouth so they don't break their teeth. Yeah, that doesn't sound like a very good idea because then they chomp down on it and splinters get in their mouth, and that's not a good idea. I don't know who thought of that, right? Why do we lay them on their side?
Because vomit can obstruct the airway.
Good, vomit. And the other thing, guess what can obstruct their airway on top of vomit?
Tongue.
Their tongue. Yeah, so at least if you lay them on their side, they can do the whole dog thing with their tongue hanging out, right? So that's the main thing. Now, what if they're having an absent seizure? What do we do? What's an absent seizure look like? Anyone have an idea?
That's one where they're just sitting there, blank face.
Yeah, they're spaced out.
Yeah.
Right?
Just
They're
leave
just,
them alone.
yeah, you just leave them alone until they come. You constantly give them contact because there have been some studies that have shown that even while they're having a seizure, if they're having that absent seizure, they can still hear you, right? And sometimes that may be enough. I've seen it where I've seen some kids where the mothers are able to bring them out of their absent seizures by talking to them and kind of talking them through it. Okay, you're having a seizure now, and I think it's more reassuring for the mother that she knows what's going on as well, right? But for the most part, for seizures, we can't do anything. We just kind of got to let them go through the seizure. Can we bill for that? No, unfortunately, right? We can't bill for watching them have a seizure. This looks good. I'll bill neuro for this. Doesn't work that way, right? But we should want to note it if they have a seizure during our treatment session. So that's our epileptics. Any questions on the epileptics? Okay. Antispasmeds, right? The antispastic meds are going to be exactly like they sound. The goal is to relieve spasticity. And remember that spasticity is a type of hypertonicity, but it is not just hypertonic, right? Somebody can be hypertonic and kind of really reactive, but that doesn't mean they're spastic. What is the ultimate form of spasticity that you might see? Causes what? Or it starts with a C.
Contractures.
Could be causing contractures, good. But before that, the repeated beating. Clonus, there we go, good. Yep, exactly, bro. So clonus is that where the muscle just keeps going, right? And if they're having clonus, obviously we stop it, right? That's exactly how we stop clonus. We just put our hand on it and just say, no clonus, no, yeah. And then he's like, nope. Because if you do that, all this is going to do is make the clonus worse. So just like all spasticity, we do deep pressure and ice. Those are the easiest ways to relieve spasticity, even if it's clonus or not. So you find the muscle belly, right? So if I'm constantly spastic into extension, right? I go out to that lateral wad, I put some pressure on it, or I do ice massage. And I kind of relieve that spasticity and let it kind of work its way out, right? It's the same thing with when you have those patients that are having that spasticity, the more you resist it or the more speed you put on it, the worse that's going to get. So we don't want to do that. I put two of them on there, baclofen and dantrium, but honestly, baclofen's the big one. Baclofen is kind of the common antispasticity med, to the point that there are now baclofen pumps, which work a lot like insulin pumps. They're a little pump that the patient wears. It's kind of in the body and it delivers them a constant dose of baclofen. What patients might have spasticity meds? What types of patient diagnoses?
Parkinson's.
Okay, Parkinson's, maybe. Yes, upper motor neuron injuries, great. That's fine, Jason. CP, good, right? Spinal cords, right? Spinal cords would be the big one. So, because think about it, spinal cords are going to get it as well. So any of those may be on, I've mainly seen as spinal cords and CP are the two that I see it a lot with. Now, obviously, spinal cord may be an upper motor neuron injury, right, Brooke? That's right there with it. So they are going to relax kind of at that CNS level. The goal of it is to reduce spasticity. With CP, spinal cord injuries, upper motor neuron injuries, and then even Parkinson's. Yep, no problem. You are welcome. She yelled, okay, thanks. So I wanted to yell, you are welcome back.
Sorry.
I'm just messing with you. I have to have a little fun. I love doing that when I get chat and Twitch, yell back at the person. They don't like that very much. So with antispasticity and the muscle relaxers, a lot of the side effects are going to be very similar. Even though they act on different areas, the side effects are going to be similar. Drowsiness is the big one, right? And then with drowsiness, what comes along with drowsy, when your brain is kind of falling asleep, you suddenly get what? Confusion, right? Think about it late at night when you're really tired. Are you functioning the best? No, right? That's when you wake up in the morning, you're looking for your glasses, and for some reason your glasses are in the freezer. Am I the only one that's ever done that? I'm just saying, like, oh, I am. Thanks, Brooke. It makes me feel better. I actually had that happen once, right? I'm walking around, I'm like, where are my glasses? Somehow or other, my glasses end up in the freezer. I must have taken them off for some reason and grabbed them out of the freezer, and I'll grab this, put these in there. Yay. I still haven't gotten to the point, though, where I walk around the house looking for my glasses and they're on my forehead. I've never gotten to that, at least. But yes, so drowsiness and kind of that altered mental state is going to be there. Along with that, maybe dizziness, because that goes with drowsiness, right? And then what about the muscles? If that drug is working at the muscular level, what about, yeah, right, the muscles are going to become weak. And that's all muscles, right? Because it's going to have a side effect of affecting everything. It's not like it can specifically target one muscle. We know that about all of our drugs, right? Even if you take a Tylenol for a headache, it doesn't just go to your head. It goes everywhere in your body, right? So same idea there. Most of your meds, just as a side effect here, most of your meds are processed where in the body? Not only neuro, but all meds in general. Where does it get processed at?
Your liver.
The liver, yeah. So almost all drugs have hepatotoxicity, meaning they can affect your liver, right? Oh, look, the black cat has crossed our path. So almost all drugs have a little bit of hepatotoxicity. They can affect your liver negatively, right? So that's a general thing for almost all drugs that are out there. If they're not processed in your liver, then they're processed in your kidneys, and then you end up with kidney problems. So whichever. Good things all around, right? If the drug has effects at the CNS or the PNS level, then you have to be worried about tolerance too, because eventually they're going to build up tolerance to it, right? For us, that's not really a big deal. That's more the medical practitioner side of it, but they will build up tolerance to it over time. And a lot of times what doctors will do is they'll put them on this cycle where they'll be on the med and then they'll take them off the med for a short period of time to decrease that tolerance, and then they'll put them back on the med. And they kind of go through this wave sine form to try to keep that tolerance level as low as possible. So if they're on antispasticity, we're worried about weakness, we're worried about their balance. We're worried about, are they able to pay attention to us, right? Could that get frustrating working with a patient like that? Absolutely, right? Because we're thinking they can do this and they're just kind of space case all over the place. Our dopamine replacement patients, and then acetylcholine regulating agents as well. What patient do we mainly see this for? Yep, Parkinson's, I see it, right? Yes, Parkinson's, I see you saying it. Good. And the two that you'll see are L-Dopa and Cinemet. Here's the good news. You don't have to be able to distinguish between the two. They both have dopamine production agents in them, right? So that means they're going to affect what part of the brain?
Substantia nigra.
Good, substantia nigra. It's going to increase your dopamine function, right? What's the major side effect of almost all of the meds that work on dopamine? Does anyone know? Arrhythmia. That's the major one, arrhythmia. So a problem with the heart rate. Now, that can be problematic, especially if somebody at age 65 or older that's taking these meds, because they probably already have what? Heart problems, right? So then you throw a dopamine agent in there that's affecting their heart rate, and it's a problem. And then the other one is GI problems. Dopamine meds really kind of have that GI distress. They don't like it very much. So what is the difference between a dopamine drug and one that affects acetylcholine? Well, it's just the neurotransmitter effects, right? Which of those two is the excitatory chemical and which is the inhibitory out of those two? Do you remember that?
Dopamine is excitatory.
Other way around. You're close. Dopamine is the inhibitory. Acetylcholine is the excitatory. There are two sides of the same coin, right? So they counter each other. So if you have a high dopamine levels, that means that your acetylcholine levels are going to be low. If you have high acetylcholine levels, that means your dopamine levels are going to be low, right? That's the side. That's why Parkinson's patients get that tremor. They have too much acetylcholine in their blood, in their system, right? That's what causes that. And you find as they take their meds, guess what happens to that tremor? It slowly stops, right? So it's interesting that we can use drugs to either counter acetylcholine or increase dopamine to treat these patients. Now, most of these, your substantia nigra is back there towards your cerebellum, right? So that means it can also affect your cerebellum a little bit, which could then cause balance and ataxic problems as well, but not as common. The main thing they're going to ask you about the dopamine meds is arrhythmia, right? So that means during treatment, what do you want to monitor? BP and heart rate. Good. Yeah. So that's going to be, they may say something where the patient is on Cinemet, or they may say they're on dopamine. What vitals would you want to monitor on this patient on a consistent basis, right? And obviously BP and heart rate would be the big ones. Now they may have BP, they may have heart rate, they may have BP and heart rate, right? And then they'll have other vitals that are non-existent, right? Temperature, not a concern, right? Breast rate, not really a concern. So those are the kind of things you're thinking about.
So what would be like the most appropriate answer if they have?
Well, they're not going to have
BP
both. They're
and
not going to have
heart?
both blood pressure and heart rate, Diane. They're going to have one or the other, or they have them grouped together. Does that make sense?
Yeah.
If I had to pick, I'd say heart rate is probably the most important,
Okay.
right? But again, they're not going to make that's a splitting hairs. They don't like those questions. So that's our dopamine acetylcholine ones. And again, I put like Matapar there, but they're not going to ask you about Matapar because I actually had to look it up. I had no idea what it was. So they're not going to ask you about that. And then we get down to our muscle relaxers. The muscle relaxers work at the CNS level. And the main idea is what is the name of that part of the nerve cell where the signal gets transmitted from the CNS to the PNS?
This is going to be wrong. Schwann cell?
That's going to be wrong, yes. Schwann cells lay down myelin. It's the part back that comes off the spine. That's a little bump right when it comes off the spine. Instead of
Dorsal ganglion.
that's dorsal, that's sensory. What's the front one called?
Frontal.
The ventral, okay, or anterior, not root. The root that comes off it. The root goes to the horn cell. Yes, Diana, the horn cell, right? That's how we determine if it's an upper motor neuron or lower motor neuron. Remember we talked about that briefly? That anything before the anterior horn cell, that means CNS level, is an upper motor neuron. Anything after that is the lower motor neuron. Your muscle relaxing agents work kind of at that anterior horn cell. So they slow down the signal transmission. So if it's slowing down the signal transmission, right? We already said kind of that they get a little bit of dizziness, sleepiness type stuff like that because it works with the antispasmeds, right? What else could be slowed down? Well, signals to other muscles too, right? Now, good news is for those the muscle relaxing agents, it usually doesn't affect your heart rate or that. Why would it not affect your heart rate? What nerve controls to kind of regulate your heart rate? The one that goes everywhere. The vagus. Right? Yeah. That's okay, Riley. That's why we're covering it. Well, eventually what's going to happen is you'll be sitting at your board, you're like, oh, Mr. McKeever's talking in my head. Right? Don't you guys wish you could just put an earwig in and be sitting there and go, the question is this, Mr. McKeever, what's the answer? That's already happened. It's already happened. So the vagus nerve comes off the brain, right? So typically the muscle relaxing agents don't affect those cranial nerves as much. So that means, right? Think about it then. If I'm having kind of muscle problems with the face, that means those muscle relaxants aren't going to work as well on that, right? Because again, that's kind of a cranial nerve issue. The muscle relaxants are only going to work on those PNS muscles down below everything. So the main idea with muscle relaxing agents, which goes to this antispasticity, is just making sure your patient is safe, right? So making sure you're guarding them effectively. You have a what on them? Gate belt, good, yes, right? ABGB. We just had a student fail the practical because they didn't put a gate belt on the patient. And I'm just like, like scream. Yes, I know. I was just like, and the best part was, it wasn't even my patient, my student. I was sitting in the back and I saw it, and I'm like sitting back there cringing. And the person that was testing with me is like, what is wrong with you? Should I be
Don't tell me
scared?
they were testing with Dr. Oreskes.
What'd you say?
I hope they were not testing with Dr. Oreskes.
They were not.
Okay, good.
They were testing, I think, with Dr. Arata, if I remember correctly. Because Dr. Arata is now lab assisting for us, guys, by the way. You guys met her, right? She was one that came into your cupping class. Yeah, so she's coming in. We brought her in to help with lab assisting to take a little bit of load off me. It's not really helping. But she's really great. So safety, right? That's the main thing for both the muscle relaxants and the antispastic meds. Are we okay on the general neuromeds? Again, that's what you have to worry about. You don't have to know how Flexerol is different from Valium, right? You don't have to know the difference between the different muscle relaxing agents. You just have to know what their side effects are going to be for you. All you have to know is that you all want Valium after your test. Because it's also causes your brain to relax too a little bit. Just kidding. I'm joking, YouTube. I am not promoting drugs.
So for the muscle relaxers, we would
Yep.
still side effects would still be weakness,
Sleepiness. Yep.
confusion.
Everything that we just had for the antispastic drugs, right?
Right. Okay.
So I don't even, when I'm looking at those, I don't even differentiate them. They're not going to ask you what the difference is between them, that one works in CNS and one works in PNS. I just try to explain to you guys so that when you see a patient that has it, why they have one or the other. All right, musculoskeletal farm. Right, so musculoskeletal farm is the fun one. So the main ones that we have in musculoskeletal, we have our disease modifiers, our glucocorticoids, our non-opioids, our NSAIDs, and our opioids. So we're going to start at the top. Our disease modifying anti-rheumatic agents are drugs that are going to affect patients that have what type of a condition?
RA.
Yeah, RA is the big one. Good. Yeah, that's the big one. Right? And it's unlikely that they're going to give you a specific like Rheumatax or Arava or anything like that. More than likely, what they're just going to say is your patient is on an anti-rheumatic. And as soon as you see that, you see rheuma, start thinking rheumatoid arthritis, right? And then think about what's going on. So the main side effects of these, honestly, is nausea and vomiting. That's it. They can get like other side effects like pain, swelling, stuff like that. But for the most part, it's just GI issues. But the thing that they're looking for with most of them, if they say they're on an anti-rheumatic, is do you know what disease they have? Does that make sense? If it says they're on an anti-rheumatic, you're going RA all day. Or it could also be something like lupus, right? Because lupus and RA are pretty close to one another. So one of those two would be the big kind of idea there. And those anti-rheumatics, what they're going to do is try to minimize the joint damage, right? Have you guys ever seen a commercial where they talk about, my doctor showed me what my joint damage will look like over time? I forget what commercial, what medications for it. So I watch late night television, so I get to see them all. But they actually do have a joint damage simulator that shows what RA can do to your joints long term. If the patient is on these, what joints would you probably be checking for swelling?
Metatarsals.
Metatarsals, right? And the metatarsals and what goes along with the metatarsals.
Phalanges.
Phalanges, good. And the metacarpals, right? So we're gonna check their feet and hands. You may check their knees. The knee is another big one I was gonna mention. So don't totally freak out there, right? But we're gonna check our fine joints first, right? Because if you look at RA, the main thing they get is that kind of that gnarly hand type thing where they get the nodules in the hands and the feet. So it may say, you know, your patient is on an anti-rheumatic, where would you check for swelling? At that point, it'd be in the hands or the feet, right? It could be the knee, but unlikely, probably hands and feet. So that's pretty much it for the anti-rheumatics. I'm gonna be honest, it's not a huge group. The glucocorticoids, right? Glucocorticoids are a little different than they work along with your NSAID. So glucocorticoids mean what type of drug? A corticoid is
It's a steroid.
it's a steroid. Yeah, it's a steroid. Good, right? So glucocorticoids like Demacort, Cordral, anything like that, they're going to work at kind of the hormonal level dealing with the steroids, right? And mainly, again, probably if you're looking at it from a pharmacological level, it's either going to work on cortisol or testosterone or something to that effect, right? But again, that's not part of the boards, but just kind of speaking in general. They're going to overall affect your body in a way that deals with that. Now, yes, it's a form of steroid. Yes, Brooke. It's not the anabolic that you would normally think of. It's are they catabolic? Don't quote me on that. I think they might be called catabolic steroids, but don't quote me on that. So what are the side effects of these? Well, almost all steroids, the major side effect is GI issues. Doesn't matter what it is. Doesn't matter if it's even somebody that injects anabolic steroids. They get nausea, vomiting commonly, right? But with the patients that are on glucocorticoids, specifically, stuff that is specifically Dermacort's the one that I see a lot. A lot of times you'll see this on patients that have something like, oh my God, I'm trying to think of the disease. Psoriasis. There we go. That was the word I was looking for. A lot of your patients that have psoriasis will be on a glucocorticoid. And Dermacort's the main one you see there because derma means what?
Skin.
Yeah, skin. Exactly. Right. So they got some skin in the game. I'm funny. The two main things they'll mention in the boards about glucocorticoid agents is either A, the fact that they can cause muscle wasting, right? That's the major one that's going to happen, right? So they can cause muscle atrophy or muscle wasting to happen. Specifically ones that work on cortisol, but you don't have to know that. But that can cause muscle wasting. The other thing it can cause, does anyone remember what disease being on long-term glucocorticoids can cause? There's a very specific disease. Yep, it's in the face. Good. Was that not you picking it? Or was that, did you actually know that? Yeah, it was. Cushing's. Cushing's is the major disease they can get, right?
Moon face, right?
Yeah, moon face. You got it. Yep, you got it. Right? Cushing's is the major disease that they can get from a moon face is a common sign of Cushing's, right? Yes. Cushing spelled that way. Yes, right? You're sitting on your Cushing's. Wait, no, it's Cushing's. So those are the main things they're going to make sure that you're affecting. Now, if it's a steroid, it's also going to affect their immune system because any steroid affects their immune system. So what safety precaution might you want to wear when you're around that patient? Gloves and a mask. Good. Yeah, right. Because you don't want to, if their immune system is suppressed, you don't want to give them whatever you have. And right now, you can't tell me, I don't care if that patient has Cushing's, you're not going to make me wear one of those face diapers. Oh, wait, no, sorry. Yeah, mask, gloves kind of idea. Good. So for us, the main idea is knowing that it can cause Cushing's and that we want to protect them immunologically, right? So wearing gloves and masks. All right, non-opioid analgesics. Pretty much the only thing we have there is Tylenol. I mean, aspirin can be in there as well, but aspirin's technically an NSAID, and aspirin has some other effects as well. But Tylenol is the main one there. So what do non-opioid analgesics do? They relieve pain, right? That's the main goal of them. The side effect for these typically is gastrointestinal, again, nausea, vomiting, mainly. But the other thing that they can cause, because all of the non-opioid analgesics, including Tylenol, are processed in the liver, they can cause hepatotoxicity, right?
And
the
does
only
it also cause like thin blood, like internal bleeding?
aspirin definitely could, yeah, right? Yeah, they can. Not as common for regular Tylenol, but definitely for aspirin. The other thing that you want to make sure of, and I've seen questions on this, if a patient is on a regular dose treatment of Tylenol, what do they definitely not want to do? What else would affect the liver?
Drinking.
Yes, drinking, right? They want to avoid alcohol. So that's the thing I've seen on some of the pre-questions is when your patient's on a regular dose of non-opioid analgesics, which of the following recreational activities would you want to avoid? Drinking is that recreational activity they want to avoid. Whiskey's so good with Tylenol, I know, right? Even better with Tylenol with a little bit of opiate, right? I mean, no, I didn't say that. Kidding, joking. So that's it for those non-opioids. Again, nausea, vomiting, hepatotoxicity are the main ones. Or let's go with NSAIDs first. NSAIDs are non-steroidal anti-inflammatories, right? That means they are not steroids. Your two big ones, Advil and Aleve, are out there. Aspirin has some NSAID effects as well. The main questions I've seen with these are what do they cause? Nausea, vomiting, again, right? But the other thing about these drugs are typically, is the anti-inflammatory effect immediate?
No.
No, right? It takes time to build up, and that can be in like a week or so. So it takes a little bit of that time for that med to build up. And that can become problematic for the patient because the patient takes the drug thinking it should work right now, right? They take those 800 milligram ibuprofens and like, why is it not working? Well, it's because it takes a little bit of time to build up in your system. So that means they need to continue taking it. So one of the things that the boards may say about these is your patient is on a long or high dose ibuprofen and says the drug is not working. What should you recommend to do? And one of them will say, discontinue the drug. No, right? If there's any question about what should you recommend to do, what should you recommend them to do? Well, continue taking the drug until you do what? Consult the doc. Yeah, keep taking them and then consult the doctor, right? That's the main idea with those questions. And then our good old opiates. All right, opiates, Demerol, Oxycontin, hydrocodone, fentanyl, hydromorphone. There's all kinds of them out there. Originally, these were designed for severe pain cases. So somebody that has cancer pain, has had an amputation, stuff like that. Now, like people go to the dentist for a toothache and they're given Demerol, which is great. Sounds like a fun time, right? Anyway, side effects of these. What are some of the side effects of opioids? What's the major one? It's a major side effect of opioids, other than addiction.
Constipation.
Can be constipation, good, right? Yep, constipation and sleepiness, right? Drowsiness. It's going to cause some sedation. So sedation then is going to cause confusion and balance issues and all that fun stuff. So we have to extra guard them. The only other question I see about those opiates is recognizing addiction-like behavior, right? So your patient constantly asks for the drugs. Yes, they're increasingly asking you for the drugs, increasingly asking you for the drugs. At that point, you need to talk to the doctor. That's the main thing it's going to ask you. Say, your patient is consistently asking you for more and more drugs. What should you do? You should let the doctor know, or let the nurse know at least. Because that probably means that patient's going down that route of addiction. On a side note to this, and going away from the boards, you have just because I just had I didn't have, but I saw a patient case scenario on this. You have a parent coming into your clinic, and regularly he or she brings his or her children with them to the clinic. So they're a parent, maybe a single parent or something like that, and they come into your clinic, and you recognize that that patient has taken either, Oxycontin, heroin, whatever it is, but they have some sort of opiate on board, and they're driving. What is our responsibility there? What should we do? Okay, call the police, maybe, but do we want to get the police involved? So what happens when we get the police involved? What about this? Offer an Uber, okay, good. Are you gonna say something, Diana? Or are you just unmuting just to give us deep
Oh,
breathing?
sorry, no, I didn't even know.
I was just messing up. That's it. She just wanted to deep breathe into our thing. Anyway, so offer an Uber, right? So that goes along the roots of this this case study talked about. It's actually one of the case studies on the APTA about this. Is, you know, if we call the police, immediately that person's going to get a record, right? Because what are the police going to do? They're probably going to issue a citation. It's pretty rare that they're not going to issue a citation.
So I worked at a school as a residential treatment counselor for a while, and they always told us to call Project like Hope, and they would have licensed medical people who would come and kind of like intervene rather than just calling the cops.
Yes, that would be preferential. Yeah, right. My first thing would be, as far as my perspective when I read that, is I first of all let my PT know that I'm recognizing it. Right. Go to the PT and say, hey, you know, Sue's back again. She's really kind of out of it on her drugs. What do we recommend do? And for the most part, what I've done, I've seen in the clinic done is, again, Project Hope's the big one I've seen in Vegas, right? Usually what I see them do is recommend her call a family member to get home, right? Hey, can we call another family member? Can we call you a cab, or can we call you an Uber? I just don't feel you're safe to drive. The main thing is, don't let her get back in that vehicle with those kids, right? And if we get, yeah, keep them for a while. Exactly, right? And you're exactly right, Alex. The patient won't come back if we call the police. But if we get them help, they may be, you know, they may be reaching out for help and not know how to get it either, right? But if they get in a car and they go and kill somebody, there is a certain amount of liability that we receive. So we have to be careful about that. Same thing if somebody was drunk coming into your clinic, right? We kind of have to monitor that. Now, if they absolutely bowl their way by us and just get in their car and take off, there's not much we can do at that point other than call the police, right? But hopefully, if we're going to be a little bit more kind of caring and try to get them help before just calling the police and getting their record. Also, if we just call the police, what's probably going to happen to those kids? Where are they going to end up? Custody, yeah, right? And we don't always want to do that either, right? The best option for a family is for the family to stay together. Even if, you know, and Project Hope, I'll say, and like Riley said, Project Hope has been phenomenal in helping these patients, and they'll send somebody pretty quick too. We had it once at the clinic where we had somebody like that, and like within a half hour, and so we just kept treating the patient like they were there, and the Project Hope counselor showed up. And yeah, the patient got a little upset about it, but admitted they had a problem. So with most of the opioids, safety, 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 safety. That's the thing with opioids. All right, cardio meds, right? Cardio meds are the fun ones, because these are the ones that seems like all of you are worried about. Because there seems to be so many cardio meds, right? You have your AAAs, you have your ACEs, your anticoags, your anti-hyperlipidemics, your antithrombolytics, your betas, your alphas, your calcium channel blockers, your diuretics, your nitrates, your posios. There's all kinds of meds out there. For most part, if you get a question and the patient is on a cardiac med, the main thing is monitoring vitals. Monitor vitals. Monitor vitals. How often should you maybe monitor a vital that if a patient's on a heart med? Maybe 3 times a visit, right? Pre, mid, post, almost like you've done that before in a comp, right? But just kind of keeping an eye on their vitals. But we're going to kind of go down through the meds, and we'll start kind of an idea here. Here's a hint. If your med has CARDA in it, that means it's a what type of med? Heart med. Yeah, it's heart agent. Yeah, right. So pay attention to that. If you see something like Cardura, Vasocarda, any of those type meds, it's a heart agent, right? So the AAAs, the alpha androgenic agonist agents, right? Those meds are used to reduce peripheral vascular tone. So what do you think that means they're going to be used to treat? Peripheral vascular tone, PVD, maybe, good, okay.
It's heart failure.
Heart failure, good, right? Peripheral artery disease, yeah, those are the three mains, right? Maybe blood pressure, they could be used, but we mainly work on the heart with blood pressure to start with, right? So they're made to treat those kind of the vascular diseases that are out there. And, so if they're made to reduce peripheral vascular tone, and peripheral vascular could also mean the blood vessels going to the brain, what do you think one of the major side effects is going to be? If it reduces pressure,
Hemorrhage.
maybe, not primarily. If it's reducing the pressure, they're going to get orthostatic hypotension, right? Because if the pressure is already down, when we change positions, what's going to happen to that pressure even more? It's going to keep dropping. So for most of my AAs or AAAs, orthostatic hypotension is the big one. And actually a lot of these meds, orthostatic hypotension is the big concern, right? And that goes along with monitoring the vitals. Some of them will cause drowsiness as well, but not as common. Mainly it's that the orthostatic hypotension. So again, AAAs, Cardipress, mini press, any of those. Again, if they say the patient, and usually what they'll say is patient is on a AAA medication. That's usually what they're called kind of colloquially, AAAs. That means that they're on a heart med for peripheral vascular issues. That means they're going to have orthostatic hypotension. We're going to guard them while transferring. The ACEs, right? The angiotensin converting enzyme inhibitor. Angiotensin, what does that break down into? What would that mean, you think? Angio meaning what?
Blood vessels.
Blood vessels. Tensin or tensin, pressure. Angiotensin means blood pressure, right? I don't know why we couldn't just call these blood pressure meds. We got to come up with fancy names for them, right? The main thing that they're treated here is either hypertension or congestive heart failure, right? So if it's affecting the blood pressure, what is our main side effect again?
Orthostatic hypotension.
There you go. Yeah, that's it. Orthostatic hypotension. And what are we going to do for it? We are going to
Monitor vitals.
monitor vitals. Yes, and guard the patient. That's it. That's all there's to it. Capitin, Vasotec, or usually the angiotensins usually have something to do with the vessels in them. Vasotec, Vasotin. A lot of them have vaso in the name or somewhere in, especially if it's the generic name. A lot of those have vaso somewhere in the name. And honestly, if you look at most of these meds, they're all pretty much the same med with like a carbon chain difference.
Mr. McKeever,
Uh-huh.
I thought are those ACE and inhibitors? I thought it was also the prills.
Yeah, I mean, some of the prills are your the generic names for it.
Oh, okay. So what should we focus on?
Just knowing that if it's an ACE inhibitor, that you gotta monitor blood pressure. That's it. Don't worry about memorizing names, Brooke.
Okay.
That's what I'm trying to get through your head right now. Is if it's a heart med, orthostatic hypotension, guard, monitor vitals. That's it.
Okay.
I mean, don't freak out. Yeah, there's tons of meds you could study, but the prill, yeah. So like lisinopril, vasopril, all those, right? Those are all the ACEs.
Okay.
But the main idea here is you can recognize by looking at, most of the time they're going to ask you, I think vasopril is Vasotec, if I remember correctly. And lisinopril might be Capotec or Capitin. But the main idea there is if you see that they're on something for, what it'll say, a lot of the board questions will say, your patient is on X medication for congestive heart failure. Your brain automatically goes, blood pressure issues, orthostatic hypotension, guard, monitor vitals.
Okay.
Does that make sense? Or they're on it for high blood pressure, HTN. Same ideas, boom, boom, boom.
Okay.
Anticoagulants. These are not known as blood thinners. Mr. McKeever will need to take a anti-epileptic if you keep calling them that. Anticoagulants inhibit platelet agglutination, right? So that means anticoagulants work kind of at the platelet level. And that means they also stop clots. What would we be worried about with these meds?
Like safety, because if they get cut or like bruised.
Yeah, exactly. Bleeding and bruising, right? Those are the main ones, bleeding and bruising. That means when we transfer the patient, we need to avoid secondary injuries, right? That's the main thing. So no ripping the skin, gently sitting them up and sitting them down, not letting them flop and get bruises on the ischial tubes, stuff like that. That's the main idea. So avoiding any bleeding and also educating the patient, right? Telling them that, hey, you're on these meds, you need to make sure that you don't get any wounds. I've seen this with a patient that was diabetic that was on an anticoagulant who got a wound on his foot and didn't realize he had a wound on his foot because he had peripheral neuropathy. And when he took his shoe off, the shoe was almost filled with blood. Because he was up and walking, all that blood's going down there and he was bleeding like literally like the dam. So paying attention to making sure they don't bleed out on us. Our anti-hyperlipidemic or our anti-cholesterol meds, Lipitor, Zocor, the big ones. It's used to treat patients that have high cholesterol. That's the major thing it's used to treat, right? What are the side effects of this? GI issues. And the main reason is because when you take these meds, at least from a little bit different standpoint, when you take these meds, the anti-hyperlipidemic can't recognize whether it's in the blood or in the gastrointestinal. So we all eat a little bit of fat every day, or we should, right? We're supposed to have a certain amount of fat every day. Now, let's say you're on one of these meds, you take the meds, and then you eat some pizza, right? Have you guys ever seen them make a pan pizza before? It's pretty disgusting. I had a friend that worked at Pizza Hut. I will never eat Pizza Hut again after seeing him make food there. Because literally they have this giant vat of basically butter or something like that, that they fill the bottom of the pan with before they even put the pizza dough in it. And that's how they get the taste of their pan pizza. But let's say they take that, the med can't differentiate between the fat that's in the stomach and the fat that's in the bloodstreams. So it may redo. Yeah, the liquid gold. Yeah. Yep. That's what they call it. It's their selling point, right? I don't know. Every time I eat pizza now, I just visualize that and I can't do it anymore. Oh, not that I'm sure that Papa John's and Domino's are any better. I'm just saying. So with anti-hyperlipidemic meds, the main idea is GI issues. Sometimes they will get headaches. But for us, the main thing we want to do is if the patient's on an anti-hyperlipidemic, exercise. Because exercise increases HDL. And that improves our overall cholesterol levels. So that's one thing we need to tell. And so what if they say, I don't want to be on these meds? You tell them, well, if you don't want to be on them, start exercising. Can't guarantee they'll get off it, but they might get a reduced load then. Antithrombotics. So these are the medications that inhibit platelet aggregation. I'm just going to call it that. The platelets gathering together, right? They're very similar to anticoagulants. And the good news is when we're talking about anticoagulants, antithrombolytics, and then also the thrombolytic medications, they all have the same thing we're worried about, bleeding out. That's what you have to worry about for them. So I wouldn't even differentiate between a Plavix and a heparin. Yeah, so they prevent agglutination or accumulation. Basically, they prevent platelets from joining together, right? Platelets have a sticky substance to them, and that's how we get clots. Again, from a standpoint, they prevent blood clots. Yeah, from a standpoint of a higher level type knowledge, the main idea is anticoagulants mainly work on certain platelet clotting factors. The antithrombotics, any of that one, the AA there, antithrombotics, ATs, they work on almost all of the factors. So that means they're just going to affect everything. It's going to definitely prevent clotting in general. But the main idea is just remember that they're the same. So Bayer and Plavix are your two main ones there. Plavix is the big one a lot of patients are on after surgery. And that's just so that they don't develop a clot after surgery. All right, your betas. Most of the betas are going to have an SOR after them. So low pressor, 10 pressor, Tenormin's another one of them. But again, beta andrenic blocking agents decrease cardiac oxygen demand. So they decrease the heart's need for oxygen, right? And they also decrease heart rate and the heart's contractibility. So they're trying to reduce the heart what?
Cardiac output.
Yeah, they're going to try to reduce the cardiac output, reduce the heart workload, right? So what would be the patients, what type of patients might be on these?
Someone just
Congestive heart failure.
CHF, good. And there's one more major one, patients that have already had a
open heart surgery.
open heart surgery, right? Or heart attack. Yep. Right, either of those. So those are the main ones that these patients are going to be on. Ironically enough, these can also be used to treat migraines, but then yeah. And it makes sense because a migraine a lot of times is a problem with blood flow to the brain, right? So these are usually too much blood flow to the brain. So it makes sense that it could be used for that, but again, not that. So again, with all the other meds for the heart, what do? Vitals.
Orthostatic hypotension.
Orthostatic hypotension. Good. And then protect. Yep. There you go. Yeah. Now this one can also cause bradycardia, which would make sense. If it's reducing the heart load, that makes sense. It's going to cause bradycardia, right? How would we know that? We'd monitor vitals, right? What about working them out hard? Would you want to monitor that? Because think about it. Their heart rate's not going to go up regularly. So you've got to monitor the workload you put them on. So that's the major thing for us is, specifically with the betas, is monitoring how hard we work them. Because they're not going to react like your average patient. So you put them on the treadmill and make them run at 9 miles an hour. Most of us, our heart rate's going to skyrocket, right? Well, they're on a medication that keeps the heart from skyrocketing, which means they're probably going to do what if you put them on the treadmill?
Pass out.
Pass out. Yeah. Right. So we got to monitor that while we're working.
So what are we monitoring? Your heart rate is not going to help. Do we use RPE?
Yep. Yeah. Yep. That's exactly good. You beat me to saying it, but yes, you'd monitor RP. How are you feeling? On a scale of 0 to 10, what do you feel your exertion is right now? Because they will feel the exertion. They just won't feel the heart because the heart's not reacting normally. And they're going to say, man, this is... yes, if you're using this traditional scale, Brooke, yes, I don't ever use traditional scale. I'm going to be 100% honest. I use 1 to 10. So 1 to 10, I want them somewhere like a 4 to a 5.
What do the boards use?
Boards typically, excuse me, sorry. The boards typically lately have been using the 0 to 10 scale.
Oh my.
Now, could you possibly get a question on the traditional scale? Sure. Right, but it's not that hard. If you know the 1 to 10 scale, it's not that hard to convert to the 7 to 20. Well, again, this is where we get into the problems because there's one scale that says it's 7 to 20. There's another scale that says it's 7 to 22. So does anyone remember why we use the scale that's the oddball one? The traditional scale?
Isn't it because your heart rate correlates to the numbers?
Yep. More than the heart rate, the output correlates to it. There's actually a formula you can use in like with a patient or a cardiac wing that can kind of calculate it. But from what I've seen, Brooke, for the most part, the boards used, I've been using the 0 to 10 scale, mainly because it's easiest for the patient. And it's more consistent. But make sure you kind of understand the other scale too. All right. So that's our betas. Now we're going to go to our Ccbs, our calcium channel blockers. Most of these, again, if you look at them, procardia, cardiazine, cardia this, cardia that, cardia this, heart med, right? So what do we know about calcium? What's in the bones, right? We know
Calcium.
that. It says calcium channel blockers. So what do you think that it's going to block? It's not a trick question. The calcium channel. Good. Yeah, right. It's going to block your calcium. So what type of a test might this patient be put on for this? It'll say the patient has hyper or hypocalcemia, right? If they're on a calcium channel blocker, that means that the calcium that's in the blood is going to go which way? Low or high? Take a guess. Okay, I got a low. Okay, stress test, good. Yep. It's going to go high because it's blocking the channel of absorption. Think about it. So calcium channels in the heart help keep the smooth muscle kind of pumping at a rate that's normal for most people, right? The goal of it is to reduce the effect of myocardial infarction and the risk of it. That's what the main goal of Ccbs are, right? Is to reduce the chance of you having another heart attack. So they're going to block the calciums at the heart. It also affects vasodilation and also affects oxygen demand on the heart. Sorry, I don't know why I'm losing my voice. But in the case of this, you're going to end up with a high calcium count in the blood because the heart is no longer absorbing that the load that it normally would. Where does the heart get its calcium from? Where's our storage site for calcium?
Bones.
Bones, good, right? What cell is going to take the calcium off the bones for delivery to the blood system?
Parathyroid.
Okay, those are good. Those are yeah. Yep, you're right. But even more commonly, what's the more kind of colloquial name for them?
Osteoblast.
Other way.
Class.
Osteoclasts, right? Remember that osteoblasts build bone, the B. Osteoclasts chew bone, C. So they're going to come in and rob the calcium off the bone to give them the blood system, right? Or to make sure that if you have the other thing osteoclasts do is like if you had a fracture, what would be the symptoms, body episode changes for someone taking calcium to prevent myeloma? So we're going to get there actually, Alex. I'm just kind of building up to that. Give me a second. So the osteoclasts also, in case you have a fracture and you get like a callus over that fracture, the osteoclasts are going to break down that callus so the bone gets smooth again. The idea of the osteoclasts is they take calcium from the actual bones to deliver to the bloodstream for use elsewhere, right? So what happens when the patient takes the calcium channel blockers is, again, much like the previous ones, the betas, it reduces the heart workload. It also reduces how much oxygen that heart needs, and it makes sense. If you've already had a myocardial infarction, you've already got part of the heart that died, right? Because it lost blood flow or lost oxygen, right? And so that means the rest of the heart probably has the chance of having another one. So it's going to reduce the oxygen need of the heart. So in process of doing that, it's going to regulate the rhythm of the heart and kind of affect that rhythm, usually slowing that rhythm down. When they're on it, they're going to end up with dizziness because the brain's not getting the necessary blood flow, right? They'll also typically end up with maybe a little bit of a headache and, again, low blood pressure. So hypertension concerns, right? In the medical field, one of the things they're going to monitor is their blood calcium levels. They're going to look at, that's how they'll base how much the patient has to take. Because we can't have way high hypercalcemic levels. There's a certain therapeutic range we can have and still be safe. But we also don't want them at that point to have hypocalcemic levels and where they're robbing the bone of all the calcium. Oh, you'd ask you that? Calcium levels. I'll get that before the end here. Blood. Brooke, I said blood. I'll get that for you, blood. Don't worry. I forget off the top of my head. So I'll look that up here before we're done. But again, with CCBs, monitor blood pressure, safety, vitals. Again, heart rate in general, heart meds in general. Diuretics. These patients are going to have one specific letter of the alphabet. That's the problem. Does anyone know what that letter of the alphabet is?
ADH.
Okay, well, yeah. That's the letter of being funny, P. Right? Oh, I know, right? I'm bad. So a diuretic agent, yes, it is going to counter ADH, right? Because the antidiuretic hormone is keeping you from having diuretics. So the diuretics, diuretic Lasix is your big one. The main idea of that is a patient that has swelling throughout their body, which is typically caused by what?
Congestive heart
Kidneys?
failure.
It could be kidneys, could be congestive heart failure. Those are the two main ones, right? Which heart failure?
Left-sided.
Want to go again?
Right-sided.
Right-sided, yeah, there we go. Remember, right side blocks up the body. Left side, lungs. That's the way I always remember. Left goes lungs, right side body. Right, so these patients, if they're on a diuretic, typically are going to have either kidney issues or they're going to have right-sided heart failure type issues where they're having swelling throughout the body. Now, they can also give it to somebody that's got lymphedema as well, right, to try to help push some of that fluid out. And if the patient has really high blood pressure, right, like super high blood pressure, they might do that in order to reduce the liquid load in the blood. Downside to that is if you reduce the liquid load in the blood gets a little thicker. That means when it does have that hypertension, it's harder to pump, right? So there's a balance there, right? Excuse me. If the patient's on this, if they're peeing out all their fluid, what is going to be the major side effect?
Dehydration.
Dehydration. That's it. Yep, there you go. Right? And then the other side effect is low blood pressure. So that means we're going to monitor vitals, safety, and orthostatic hypotension. It's amazing how these all work, right? And then we're also going to encourage them to do what?
Drink water?
Drink water. Yeah, offer water. Yep. Yeah, these patients need to drink a lot of water because the goal is to flush it out. And it seems silly, but the more water they drink, the better the diuretic works. And it flushes out all that thick, viscous fluid out of their body so that swelling goes down.
Usually they don't want to drink water though, right? Because they're get so tired of going to the bathroom.
Yep, exactly. You're 100% right. So the patient doesn't want to drink because they're like, I'm peeing all the time. But
So
then
the
we
best
want to tell, go ahead, I'm sorry.
No, go ahead. I was gonna say, so the best thing we can tell them is like what you just said.
Yeah, that's the point of it. This is going to stop that swelling in your body. I know that you have to pee all the time, but think of how painful the swelling is to you.
Okay.
Right? Yeah, they don't want to drink because they're peeing, right?
This might not relate, but do you take this at all with lymphedema?
You could. Yeah, I said they can prescribe it for patients with lymphedema. They have to be careful with that though, because again, lymphedema is usually, especially like primary lymphedema, the fluid is really thick. So it's harder. You don't necessarily want to get that fluid back into the bloodstream, which could clog up your bloodstream. Does that make sense?
Yeah. Okay.
So it's a balance. If the patient's really good at drinking water, you know, really hydrating, yeah, they could put them on this to help with lymphedema.
Okay. But it's not really for that.
It's not a primary one. It's majorly for right heart failure.
Okay. Thank you.
Also, I mean, you could take it for left heart failure, I guess, but not the primary reason you get it, okay? Because you're still going to get some fluid back up in the lungs. I guess you theoretically could test. Somebody just asked me that. You could, but it's mainly right heart failure. All right, our nitrates, which main one is nitroglycerin. Nitrates are typically given to a patient that is experiencing angina. Yes, right? Yes, yes, yes. It is to reduce angina. That is the primary job patient has it, right? The major side effect from this is headache, because it's going to rapidly dilate the peripheral blood vessels. Like when I say rapidly, when they gave me nitro under my tongue when I thought I was having a heart attack, holy crap, that headache hit instantly. Like it was not even a second. And I'm like, oh my God, my head feels like it's pounding. And they can't give you anything else for it. You just got to suffer through the headache, which was really fun. So headache is the major problem. But the other side effect is, because all the blood vessels are now open, blood pressure drops drastically. So we're worried about orthostatic hypotension. Yep. So we got to monitor for that. For the most part, you're not going to see a lot of patients on nitrates anymore. Just because there's so many, we got calcium alpha, channel block, all those fun blockers that we have. Nitrates are typically somebody that has consistent chest pain. They can also give it to somebody that's having a stress, not stress test, but a panic attack. There we go, that's the word I'm looking for. Because it does affect the heart and that, but I would not want it. Yeah, no wonder these patients are on all kinds of meds, right? Yeah. I'm going to speak from experience because they put me on a nitrate for a short period of time. I hated that drug. Yeah, you're going to need them next month. Specifically, some of the neuro meds we're going to talk about, or the psych meds we're going to talk about soon, right? The posi inos. All I'm going to say about this is, for the most part with posi inos, the idea for the posi inos is for AFib. So what you see, if it's talking about posi inos, specifically lamicin is the big one. It's usually AFib. Right? So AFib is the major thing when you think of those. AFib also increases a patient's risk to have a what?
A heart attack?
Nope. Well, I mean, yeah, technically, but more importantly than that.
Atrial fibrillation.
Yeah, that's what I said. That is what AFib is. But what does it increase? Not congestive heart failure, stroke. Right? So remember with AFib, the atrium's doing this, right? It's just kind of quivering. That means it doesn't fully empty when the valve opens up, okay? So that means blood sits there a little bit longer. When blood sits, what happens?
It hardens?
Yeah, it clots. It coagulates. Yeah, right? So now that blood's not fully out of there, it's sitting there for a long period of time, you get a blood clot forming there. Right? Now, if it's in the right side, where's that blood clot going to go?
Body.
Not the body. No.
Lungs?
Lungs. Yeah, right. Now, the right side goes, that's why right side's going to go to the lungs, right? And it could get a PE. Good, Alex. If the left atrium's quivering, now it's going to probably go where?
Into the system?
Into the system, but mainly one specific part of the body, the brain.
Oh.
Yeah, not necessarily the cap, Alex. It's going to go to the brain. And the main reason of that is the blood vessels that have the highest pressure coming off that aorta are the carotids. And so if you got something floating in there and it's kind of a free-floating object, it's going to find those carotids quick. And it's going to go up to the brain and they're going to stroke. So a patient that has AFib is typically going to be on these posi inos is what they're usually known of in the clinic, right? The posi inos. So that means it's going to affect their heart rate. If it affects their heart rate, that means it affects their blood pressure, which will give them orthostatic hypotension. You almost see a trend here, right? It's almost like that. It's easier than you guys think it is, right? So they're going to monitor their blood pressure, keep them safe. The last heart med are thrombolytics, and the main one that we've seen before is TPA, right? Do you remember what TPA is used for? Because it has to be given within 3 hours.
For a ischemic stroke?
Ischemic stroke, good, yes, right? So versus we previously talked about our antithrombotics and we talked about our anticoagulants. The major difference with thrombolytics is they destroy clots. They don't prevent clots. They go in and just destroy clots. They will melt clots like crazy. The side effect of that is they also destroy every single clotting factor in the body. That is why a patient that had a stroke, that was a ischemic stroke, and they give this medicine to them, they're not going to get them out of bed. They're going to have to lay for quite a period of time until they start building up some of those clotting agents again. So we get them out of bed, man, everything will bruise. It's kind of crazy. So again, the thrombolytics, the major thing is, for us, is keeping them from having any hemorrhages or bleedings. We're not typically going to see those. I'll be 100% honest. The main thing you have to understand with these patients is that the TPA has to be given within 3 hours of a stroke. That's the main idea. Again, 2 hours is what most hospitals say because 2 hours is within 3. So they're trying to be a little bit safe. That's it for, go ahead. What's that?
Will our board say 3?
Yeah. Yep.
So there's not going to be a 2 hour?
Well, I mean, the 2 hour would be within the 3 hours. So you would look for something under 3 hours. How's that for? But I'm guessing they'll probably ask 3. I don't want to steer you wrong that there won't be a question that says within 2 hours, but 2 hours is within 3, bro. They're not going to have 2 and 3. Does that make sense?
All right.
So that'll say within 5, within 24, within 48, within 2.
Okay.
So don't lose your mind on that. It's either going to be 2 or 3, and then abnormal numbers other than that, right? It won't be 1. All right, endocrine pharmacology. Endocrine is dealing with what?
Hormones.
Endocrine system.
Yes, or it's usually replacement hormone therapy, right? For the most part with these drugs, it's pretty rare we're going to get questions on these. I'm going to be 100% honest. I have rarely seen something about these just because, hold on, my brain just completely melted down there for a second. Just because this is just dealing with hormone replacement. And again, endocrine, not as big of a deal as in physical therapy as for everyone else, right? Your bone mineral regulating agents like Fosamax, Boniva, all that just help build the bones up. What patients would be on a bone regulating one? Patients that have
Osteoporosis.
Yep, osteoporosis. That's it. Good. Or Paget's disease or something like that. Or what's the big one? Oh my God, why am I drawing a Mr. Glass? Osteogenesis imperfecta.
You beat me to it.
I know, my brain was getting there, right? Or osteomalacia, where the bones are softening. That's a weird condition as well. But for patients, for us, when they have a bone mineral deficit, how do we improve their bone mineralization?
Would you obviously you give them meds, but also like Wolf's Law, make them use them more?
Yeah, yes, that's it. Yeah, right now, we probably don't want to move them when they've just had their med. Right, because there's a risk of fracture within, I think, and don't quote me, I think it's within 4 hours of taking the med, because the med kind of does this weird thing where it pumps up the mineralization and has a short period where it drops the mineralization and then it levels back out. So there's this risk of fracture right after taking the med, but we're not going to see them typically right after taking the med anyway. But again, for the most part, for side effects for that, it's just nausea. And for us, the main thing is we're going to work with patients that are on these meds to get them up and moving and use Wolf's Law. Exactly. I always forget the name of Wolf's Law. I don't know why. I should howl about it more often. Oh, come on. That was funny. I don't care what you say. Hormone replacement agents. It's going to be based upon whatever hormones are replaced, right? If the patient needs estrogen, it's going to be an estrogen replacement. Now, this is becoming more frequent that we have to deal with these meds. Why do you think it's becoming more common to encounter this?
Is it birth control?
Birth control could be one of them, okay. but also because transgender is becoming more accepted. Right. And I really we had this debate on one of the channels I'm on about everyone wants to be transgender now. It just seems like transgender is everywhere. And no, what it is now is people are not afraid as much of saying that they're transgender. Right. Yeah. That's the idea behind this, because there has been and there still is a lot of stigma. Just look at Texas. But so we're going to see a lot more. I think in the future, we're going to see this more frequently because people are more likely to come to a healthcare professional now, realizing they're accepted. And so if you have somebody that's on a hormone replacement, whatever it may be, whether it's testosterone blocker, estrogen enhancer, anything, and for the boards, the main thing it's going to ask you to do is, what would you do if you have a patient on XYZ drug? You're going to research it. That's the main thing these ones are going to be, is because there's no way I can teach you what every hormone replacement drug does. There are too many of them. But you should know that, like, a thyroxine works on the thyroid gland, right? Testosterone would increase your testosterone counts. Estrogen would increase your estrogen counts. But for the most part, we just have to be aware of that they're on it. And then also just look the drug up, research it. That's it. And then hyperfunction agents. These are patients that have stuff like a hyperactive thyroid, a hyperactive pituitary gland, stuff like that. All they do is reduce the function of that gland. They reduce the output. And for us, we have to be aware of the signs and symptoms of what their drug does. So again, for this one, it's going to ask you, your patient is on a drug that reduces the function of the thyroid. What should you do? Look up the side effects of the drug. Right. But if I give you one that's like, say it works against adrenaline, an anti-adrenaline med, you would know that what would kind of they feel like?
Lethargic.
Lethargic. Yeah. Right. So those are common ones that kind of make sense, right? Or if a patient's, like before we talk about hormone replacement, if they're on testosterone, they probably are going to have mood swings. Right. If they're on estrogen, they can have mood swings too, believe it or not. It's just depends upon if it's what they want to do, whether it's aggression or it's depression, right? So the main idea with the endocrine system is if your patients are on them, are you researching what they're on? GI issues. The main ones here in the GI are going to be our antacids, right? Probably at least one of us here probably is on this regular because they've got either acid reflux or something like that. I love this. Our major antacid is Tums because it's been around forever. It's kind of like Tylenol, right? Go take a Tums. Milk and magnesium is another one. What do you think an antacid's going to do?
Neutralize acid.
Yeah, exactly. Right. And magnesium's really good for neutralizing acids, right? It's usually given for a minor GERD, gastrointestinal reflux disease, indigestion problems, stuff like that. The major side effect of, I'm going to talk about antacids and where's the other one? The intestinal, I can never say that word, hold on. The intestinal Anti-Cholinergenics and the H blockers, which we'll talk about in a second. All of those drugs which reduce the production of acid or reduce acid in the stomach, the major effect or side effect of them is what's called rebound. So they take the drug to reduce the acid, but because you reduce the acidic effect, the body sees the reduction in acid, and what do you think it does?
Makes too much base.
Well, no, actually, it does the opposite. It produces more acid, right? It produces more. It says, oh my God, you're cutting down on my acid supply. I need that acid supply. So it kicks up the acid production. And when the drug wears off, now they get this rebound, which means their GERD gets worse. That's why a lot of patients get really bad acid reflux at night, because they take the drug through the day, they go lay down, and now the drug's kind of waning, and now that GERD kicks up, right? The main thing for us is understanding that these patients are GERD. They probably have GERD. If Alex takes Tums at night often. Yeah, so it happens, right? Especially if you're somebody that's got a high stress level. I don't have high stress. I don't want you guys to talk about, why did you guys ask if I have high stress? Stop asking if I have high stress. But when you're working on these, right, and you're talking about GERD conditions, the main idea is just to let him know that for the most part, it's not going to affect physical therapy. Almost all of the meds that affect the belly don't really affect physical therapy. They don't. So not really worried too much about them, other than just making sure that if they complain about acid reflux when they're laying down, we put them in semi-recumbent because it's more comfortable for them. That's the only thing you really have to worry about these patients. You're not going to lay them flat. Antibiotics, what are they used for?
Curing disease and then like mostly infection.
Good. What type of infection?
Bacterial?
Good. Bacterial. Yes. Right. So would an antibiotic help with COVID?
Yet.
Yet. Right. Because COVID is a virus. We need antiviral. Right. There's a big thing about that at the very beginning that the antibiotic manufacturers, when COVID first kicked in, were saying, our antibiotic helps with COVID. Sell it. But it doesn't, right? Tetracycline, amoxicillin are your kind of major. Any of the cillins, penicillin, amoxicillin, vancomycin, that's vancomycin, are all your antibiotics there. What are the side effects? What's the major side effect? What do you think?
Kills all the bacterial in our guts.
It kills all the good bacteria in your gut too, exactly, right? Which is going to cause nausea. And that's going to make you feel nauseated. So that's the main problem with those is we just want to kind of monitor for nausea, vomiting, stuff like that. Does anyone know what tetracycline is used for a lot?
Isn't it used for an STI?
Can be used for STIs, right? Yep, there's one specific one, yeah. Which specifically the one that Al Capone died of.
Gonorrhea?
Well, that's one of our friends too. Syphilis.
Syphilis, damn it.
Yeah, right. But also tetracycline can also be used for what do you call it? Pimples, for acne.
So like proactive.
Yep. Yeah, a lot of proactive has tetracycline in it, right? Especially there's one specific form of proactive that is over the counter that definitely, or not over the counter, prescribed, that definitely has tetracycline in it. But again, the side effect is nausea and your good bacteria gut goes away. So you got to be careful with that. Intestinal Anti-Cholinergenics, right? These are the medications that produce or reduce acetylcholine. Acetylcholine is responsible for a lot of your production of acid in the stomach. And the patients that are going to be on these are patients that have really, really severe GERD that have caused ulcers, right? These are like your severe GERD patients if they're on these.
And GERD is caused by bacteria, like ulcers are caused by bacteria. Is that correct?
It could be. Yeah, there's still a lot of research in GERD that it could be too much ACH too, acetylcholine. Right. So that's why they give them, they find if they give them an intestinal anticholinergic, it stops the production of acid. And it helps with those, right? So again, with this, if we get a anticholinergic, which blocks acetylcholine, by blocking acetylcholine, what other neurotransmitter is going to go higher? We just talked about dopamine. There you go. Good. Right. And dopamine makes us kind of dopey. Right. Because it's the drug that gives us that whenever you get a text message and you get that high from your text message, that's a dopamine hit. Right. That gives us that kind of that buzzy feeling. And sometimes you can get confusion from it, dry mouth, stuff like that. So we just kind of pay attention to it. Again, most of the time if they're on the anti-ACH, they're going to tell us what their problems are. Antidiarrheal, the main one is Capectolin and bismuth. Does anyone know what the two names for those really are?
Pepto-Bismol.
Pepto-Bismol is bismuth. Good. What about Capectolin? Kaopectate. Kaopectate. That's the one. The two main drugs. If you go to your grocery store right now, the two main anti-diarrheas that are sitting there are Pepto-Bismol and Kaopectate. Those are the two main ones there, right? That's the generic name, bismuth, right? Here's a trivia question. Does anyone know what the flavor of bismuth is?
Chalk.
Chalk. It has a very specific flavor they use for it. Tea berry. There's actually a specific berry called tea berry. And that's the flavor. That flavor that you get, other than the chalk flavor, yes. But the flavor that you get from Pepto-Bismol, that weird kind of, I don't even know how to describe the flavor, but that's a tea berry flavor. And back where I'm from in Pennsylvania, there's a company, the Brits' favorite berry, yeah, exactly. Back in Pennsylvania, though, there's a specific gum company that makes tea berry gum. And interestingly enough, if you've taken Pepto-Bismol in the past and you chew the tea berry gum, they've shown that you have the same effect. Your brain thinks it's Pepto-Bismol. It's crazy the way it works, right? And it can actually help with diarrhea just by chewing that gum, because your body like just goes, oh, this is Pepto-Bismol. It tastes horrible. Like I have a friend that loves the tea berry gum, and I'm like, I do not want to chew Pepto-Bismol. That is not what I want. Maybe I'll find some. I'll send you all some. That way you can taste it. It's great. Anti-diarrhea meds. What do you think the major side effect is going to be?
Constipation.
There you go. And that means intestinal discomfort. That's it. So what do we tell patients? The more they move, the more their bowels will move, right? So get up and get moving, and we can actually reduce this. When a few weeks ago, when I got really bad food poisoning, that was what one of the doctors told me to do. He's like, I need you to get on the treadmill and the bike and just run it out. He goes, it's going to literally run out of your body. But the more you exercise, yes, she's laughing at that. He's like, the more you exercise, the faster you can get those problems out of your body. Makes sense, right? Because if we exercise more, we produce more, endogenous opioids. It helps everything kind of relieve itself. So if anti-diarrhea keeps us from shooting out the back end, antiemetics keep us from shooting out the top end, right? Those are used to keep us from vomiting. Emesis is vomiting. Scopolamine and Mechaluzine are our two major ones. Now, both scopolamine and Mechaluzine are going to have two major side effects because they can also be used to treat dizziness. So they affect your vestibular system, right? So these patients that are on antiemetics will have vestibular symptoms because it kind of slows down the vestibular system. So a lot of times they'll get dizziness with it, which means we need to guard and protect. That's all we have to know about antiemetics. And then if we have an antiemetic, then we also have emetics, right? Which make you throw up. Who's going to be given an emetic?
Somebody that's had some sort of poisoning.
Yep, there we go. Good. And the main one we use is Ipecac. And if you've ever had Ipecac, you will never eat maple syrup again, because Ipecac tastes like really, really sweet maple syrup. And like to this day, I had a friend that overdosed on drugs, and they gave him Ipecac, and it smells like, they open the bottle, it fills the whole room with maple syrup smell, but then it causes them to vomit drastically when they take it, right? Sometimes they'll also give them charcoal, right? Because charcoal neutralizes drugs, which is also then going to make them vomit. But yeah, so emetic, we're not going to see a lot of patients on emetics, but what do you think one of the side effects of patients that are throwing up a lot is going to be?
Dehydration.
Dehydration. Same thing with people that poop a lot. H2 receptor blockers, right? Block the H2 production of acids. So again, it just goes back to those two antacids. It's going to affect them. So they're typically going to have rebound. And for the most part, we're not going to lay the patient how?
On their back.
Yeah, flat, right? Back or belly, just keep them from being prone or flat or back. So we need to have them angled up a little bit so that the acid goes down, not up. That's it. Same thing with proton pump inhibitors down there. So same treatments there. Laxative agents. The main thing with laxative agents we can tell patients, again, is the more they move, the less they'll need them, right? Because laxatives are going to cause the back end to go crazy, right? And you may end up with a really crappy problem if they're on it. If they're on laxative agents, be aware, as soon as they stand up, you have changed the vertical position of the colon. it is likely that they are going to poop immediately. Right. So if I know a patient that's on laxatives, I'm really careful. I usually have a bedside commode nearby. Because especially something like Colace, which is pretty potent, if they're on it, as soon as they stand up, there is no, we got to get to, I mean, if the patient can move quickly, we can get them to the bathroom. But for the most part, you stand them up, they're like, I'm going to go now. That's why I have to be a nurse. So, yeah. So Gas-X works kind of like an H2 receptor, Alex. It's a low-level H2 receptor. And it's designed, it's interesting the way Gas-X is designed, Alex. It's designed with a harder outside shell, so it works lower in the intestines. And that's usually where your gas exists, is lower in your intestines. Prune juice mixed with melted butter. It is a natural laxative. You're 100% right. Right? You know what else is a natural laxative? Coffee. Right? Caffeine is a laxative. Right? So sometimes people, unfortunately, most of us that take it regularly, it no longer affects us. You've all had that, I'm sure. Some of you have had that in the morning where you drink a cup of coffee and about 2 minutes later, your bowels are like, I need to go. Again, proton pump blockers, like I said, same thing with H2 receptors, same thing with antacids. Don't lay them prone. I think this might be the last meds, which are the psychomeds. Wait, that didn't sound good. The psych meds. Right? With the psych meds, where are we probably going to be treating patients that are on psych meds?
In the psych ward.
In the psych ward, usually, yeah. But now more commonly everywhere. That's the sad part, right? Our psych meds. Some of this, the first set is the ones you guys are going to want after the boards. The anti-anxiety meds. Or maybe before the boards, I'm not sure which. One of the two, maybe both. Right? Anti-anxiety meds are designed to kind of target the CNS that actually reduces the effect of GABA, right? GABA. And they calm you down. The most common is Xanax, right? Because, yep, you're right. And Xanax themselves, they just had a whole problem of Xanax up in, oh God, what was the thing that just happened? Electronic Daisy Carnival. There's some people passing around Xanax that was laced with fentanyl. And why would people want to take Xanax? Because it does give you a roll. It does give you a little bit of a high, right? And kind of makes you mellow and blah, blah, blah. So there are reasons why kids like Xanax. But so do suburban moms. I'm just saying. Right? Xanax, Valium are kind of anxiety meds. For all, I'm just going to say this in general, for about all of these meds, the two major side effects you have to worry about, drowsiness and weight gain. Almost all of the psych meds cause those two problems, some greater than others. Right? Anti-anxiety is not necessarily heavy on the weight gain, but definitely on the drowsiness. Don't do drugs, kids, right? Well, or at least if you do them in large quantities. I'm joking. So anti-anxieties are going to treat anxiety. If you have a patient that has anti-anxieties, what would you be worried about?
Drowsiness.
Drowsiness, good. Falls, good. But what about from their mental state? What are you worried about? Yeah, maybe impulsiveness.
I think some more depression.
Yeah, right. You also just don't want to kick up that anxiety, right? And mood swings, good. So if they're on those meds, you probably don't want to have a Mr. McKeever voice is all I'm saying, right? You want more of a nice Brooke voice where it's kind of calm and quiet, right? Or a Diana voice, it's really calm and quiet, right? Anthony and I aren't going to treat patients on anxiety. We're going to give them anxiety. It's okay, right? And also think about it. If they're on anti-anxiety meds, are they probably going to be anxious coming to physical therapy? Yeah. Right? They're worried you're going to cause them pain. And so by calming down that anxiety, we can still help them further. Antidepressants. There is absolutely no way I can teach you all of the antidepressants because there are just so many of them. I could give a whole class on antidepressants. The main idea of antidepressants are affecting the hormone or the neurotransmitter that is deficient. right? That's why antidepressants are so hard to give to patients, because a lot of times they have to try 4 or 5 different antidepressants before they get the right antidepressant for that patient. You know, we may start them on tricyclics, and then we find out tricyclics not their problem, so we try them in SSRIs, find out it's not serotonin, then we try an MAOI, and then we try an NRI. So it's just kind of balancing there. The main idea here, though, is telling the patient on these that it's going to take some time for those meds to kick in, right? Because patients want meds to just instantly fix their problems. And especially with antidepressants, it takes 6 to 8 weeks. And usually the last person to realize it's working is the person taking it, right? I remember specifically, I was shadowing a psych doc, and he asked the patient, so how are they put them on an NARI, which is a norepinephrine reuptake inhibitor. How's that helping you? And the patient's like, it's not really helping me at all. And the wife's in the background going, right? She noticed it was definitely helping him. He just didn't yet, right? And she's like, and she mentioned, she goes, he's less moody, he's this, he's that. And so it's less likely you'll notice that. Again, with almost all of them, sleepiness and that. But the other thing that can happen and we have to pay attention for is when they're on an antidepressant, it can cause a depression rebound, right? And you've all seen the commercial for antidepressants where they say in young adults may cause suicidal ideation, right? So we have to be careful and kind of monitoring that the depression doesn't get worse. Antipsychotics, some of you guys may think I need these. Haldol and Thorazine, these are to treat patients that are having psychotic breaks. The most common side effect for this is overall sensory and motor deficits. It'll shut down most of your central nervous system. Haldol is the big drug they give when somebody's getting out of control at the hospital. They'll usually give them a shot of Haldol and the person just basically goes limp, right? So antipsychotics are going to make them have all kinds of motor issues specifically. So dyskinesia, dysmetria, dysdiacokinesia, stuff like that. It may cause them to have some Parkinson's symptoms. But in general, with antipsychotics, again, you're going to see them by patients up on the floors that need these patients, and you're monitoring their psych problems more than you're monitoring what the drugs are doing for them. Bipolar meds, lithium's the big one, and it's mainly to keep them on a level, right? If you're talking bipolar, that means the patient's swinging both ways. Manic, depressive, manic, depressive. So the goal of a bipolar med is to level them out. The good news is, guess what also levels patients out? Exercise.
Or sleep.
Or sleep too, yeah, right? Leveling the patient out. So we got to talk to them about getting proper diet, proper sleep, proper exercise. And that's the main thing with bipolar meds is, for the most part, again, sleep, but also the other thing, bipolar meds, massive weight gain. We're talking, if they're on lithium, 50 pounds plus, right? You got to be careful with that. But the patients that need the bipolar meds need their bipolar meds. And a lot of them will say they don't like the weight gain, but they like the fact that they're not bipolar more than they don't like the meds. Sedative meds and hypnotic meds, Halcyon, Luminol, Haldol, all cause sedation. We are probably not going to want to see patients that are on sedatives, are we? So what do you think that treatment's going to be like? Not effective. Interestingly enough, they're finding nowadays better than taking sedative meds. You know what they're finding works even better for these type patients? Mushrooms. Right? Yeah, she's like, yes. We're finding more natural roots. Yeah, right. And also on top of mushrooms, LSD. And honestly, LSD used to be actually used in this, right? And they used to, and I think if I remember, don't quote me on this, but I think luminol is actually just medical grade LSD. I want to say it is, but don't quote me on it. It's like probably a couple carbon chains removed, right? But it does have an effect on it. And then, of course, my favorite drugs, my mind-focusing agents, ADD, ADHD, right? Their job is to keep a patient on the level with brain function. But the downside to those, what type of drugs are those? Does anyone know?
Psychotropic.
Well, they could be psychotropic. They're also meth. Yeah. Adderall and Ritalin, Concentra are all meth. So if you're taking them, you're on meth, right? They're just a prescribed form of meth. And this is really confusing. Like initially when I thought of this, I'm like, why are you giving me a medicine that basically speeds me up if my brain already is going crazy, right? But the problem is your brain function can't keep up with your brain thought.
It's like the inverse proportionate.
It is, yep. And so by giving you that medication, your brain thought and your brain function catch up with each other and you are more on the level and you can get stuff done. I will say the side effect of taking these drugs is you get hyper-focused. I sometimes think that maybe one of the faculty needs some of those. But anyway, that's me. That's what I'm talking about. It's obviously me. But I like with patients that are on these, you have to be paying attention, especially if they're on these meds. And again, what age range are you going to see a lot of these meds in? The mind focusing agents. Kids, yeah, and probably should be on more adults. That's beside the point. But remember, if these kids are on these meds, they're gonna have a hard time switching activities.
Isn't it kind of, oh my gosh, what's it called? Like it's not the greatest idea to give these kids these meds because they're so young and their brains are still developing.
There is that to it too, but the kids that need it, need it. I think it's overdiagnosed nowadays. You're correct.
No, that's not what I was saying.
Okay.
I was just talking about like,
Yeah, the brain development itself.
Yeah.
I mean, I wouldn't doubt it, but I'm going to be honest, coming from somebody that wasn't diagnosed with ADD as a child, I often wonder if I would have been able to function more readily if I took it. Like I see a lot of these since taking a psych, I'm like, man, I had all kinds of problems they never figured out. And so I think that it would have probably helped me as a kid. But you're right, maybe my brain developed better because I wasn't on the meds.
well,
Who
no,
knows?
and I agree with what you're saying because I worked in schools and I had kids that were just like all over the place. Like I don't have a good way to say it, but they were hot messes.
Yep. That's a
Yeah.
good way of saying it. Hold on a second. I'm telling somebody that I'm not available right now. There we go. Yes, my problem is sometimes takes a little bit to figure out which one works for them, because even though Adderall, Ritalin, and Concentra are all, variations of the same drug, they affect people differently. Like Ritalin didn't work for me. Didn't matter, right? But Adderall does. So it just depends. It's much like the underwear at a nursing home. It just depends. No one's laughing at that. That was funny. Okay, I appreciate it, Diana. But I think I agree with you. I think that a lot of times we may be better off letting the kid develop until they're at least out of their start of puberty before we put them on it, right? And we also know now, along those same thoughts, Riley, is that kids that take marijuana early on, we know that retards brain development, right? And again, I'm a proponent for marijuana. I believe in marijuana being a drug. I'm not so much on young, like under 15 using marijuana, if that makes sense. Right, exactly, yeah. And honestly, so one of the things, interesting story about that, we had a student from one of the cohorts, I don't remember which one it was, recently. But man, when she was in school, she was a hot mess. Like she did kind of average. She was like a 77 to 82 level student, but she had a desire to really be a PT or a PTA. And she took the boards twice and failed miserably twice. And I had always said in my back of my mind, I really believe she had ADD. And so her and I talked extensively, and I said, why don't you go get checked out? And so she went and got checked out, and lo and behold, she met all of the criteria for ADHD. And they put her on a med. The next time she took the boards, she got a 740 because she was able to focus on the test. And she mentioned, she goes, I didn't think about it, but she's sitting there in the test room and she'd see something on the desk and she sees a spot on the desk and she'd have to wipe that spot off the desk because she just couldn't focus on what she was doing. And so, you know, I've gotten a little bit more proactive. If I start seeing people that have more signs of ADD in the school, maybe mentioning you might want to get checked out. Doesn't hurt. The worst they can say is you don't have ADD and you paid for doctor's visits. Right. But yeah, I agree with you. I'm on for kids in general, I'm leery of putting them on meds sometimes. Right. But I think that if they were diagnosed and given it, it could affect things. Especially side note to that, I'm really against giving kids antipsychotics. I'm going to openly admit that. I'm going to come out and say I am against that just because I don't believe you can diagnose a kid as psychotic because their brain hasn't stopped developing. Now, are there kids that are not psychotic, but sociopathic? Yeah. Right. There are kids that are born sociopathic. But I don't believe that kids, I think sometimes we put kids on psychotic meds in order for the parents to control them a little better. Same thing with ADD meds sometimes, right? Little Jimmy's got ADD, isn't he so cute? No, it's not that. Nutrients, right? Again, for this, these are all the patients that are on whatever. I take this, I take that, I take this. Doesn't matter what it is. For us, the only thing we can do is look it up. There's not a way we can specifically say, tell them to take this or take that. What if your patient asks you, should I take a multivitamin? Can you say yes?
Nope.
Nope. Yeah, I don't. I just recommend them go to the doctor. Now, for in general, is taking a multivitamin bad?
Usually not.
Yeah, usually not, because you're usually going to pee or poop out what you don't need anyway. But I have seen some people that take way too much vitamins and they get vitamin toxicity syndrome. You know, especially people that are the gym rats that are like, I'm taking this, that, and everything. I'm getting swole, bro. And they just overdose on vitamins. I don't understand it. On that note, what type of vitamin do pregnant women need to supplement? Which of the letters?
B12.
B. Yeah, B12. Yep, that's it. B12 is the major one, right? So, well, B12 and also some B6 as well, but that's beside the point. But Bs, right? They want to be taking a vitamin B, and that's mainly because guess what baby likes to do? Steal all of it, right? And that's the way babies are. Babies are parasites. I've told you that many times. I was talking about that in the class that I just talked about for anatomy, and I was like, you know, I said, you know, specifically when women get parasites, they start having more and more problems. And they're all like sitting there and I'm like, parasites, you know, babies. And they just stared at me like, you have got so many issues, Mr. McKeever. I said, this is only first semester. Just wait. But for the most part, we're not going to talk to them about supplementing their minerals, supplementing their vitamins, anything like that. We just want to make sure that they understand that if the doctor recommended, there's a reason for the doctor recommended. Some of them, specifically like chromium pick and even caffeine and stuff like that, are going to cause them to be jittery. So we got to pay attention to that. So as far as this, before you take your boards, take your anti-anxiety meds, take your antipsychotics, you'll be fine, right? And again, the main thing is you need to know the safety. That's the most thing that you have to know. How they're going to affect and how they're going to interact with one another. If you have two drugs that cause drowsiness, the patient's going to be super drowsy, right? With all the heart meds, monitor vitals, orthostatic hypotension, and safety. Those are the major things, right? What would somebody that has orthostatic hypotension look like?
Pale, pallor, a little bit maybe sweaty.
Yep. And then dizzy. Right? Ashen face, good, right? And we're not talking about Ash from Pokemon either. That's Ashen's face. Never mind. Okay, fine. That's funny. Yeah, so we're going to monitor those. With mental medications, almost all of them, lethargy is the main side effect. And so we may want to make sure that they're not coming to see us at peak. So how long is peak time for most meds?
2 to 3 hours.
Yeah, somewhere between 1 and 3 hours is usually what we say is peak time. So pain meds, we definitely want to see them when they're on the peak time, right? because we want them to be relieved of pain. But maybe the psych meds, we might, if they say, hey, I take my psych meds at 8 in the morning, maybe schedule them for afternoon. Right? Because then they've got a dose of psych meds, but they're not at the point that they're most lethargic. So it's all kind of justifying when we want to see them, when we don't want to see them. How many meds is too many meds? What do you think?
When the dose is too much.
Yeah, when the dose is too much, right? And also, I mean, for the patients, you're like, anytime we get over 2 meds, they become polypharmac, right? We've got to pay attention to that. The other thing that happens is a lot of times the doctors don't communicate with each other. So this doctor will put them on this doctor will put them on this, and the same drugs do the same thing. I have seen it with patients that go to pain doctors. They'll go to like the pain doctor and the regular doctor, and the regular doctor puts them on an opiate, and the pain doctor puts them on a different opiate. And then they come in and they're like, yo, man, what's up? Because they're just so dopey from the pain meds. How do you deal with a polypharmac patient? Well, the main idea is find out what drugs they're on and look them up. Right now, do we talk to them about the interaction between the drugs? Maybe not, but we might tell them to look that up. There's nothing wrong with giving your patient a little say, hey, you may want to look up your drugs. Just make sure you understand what the effects of all your drugs are. Or talk to your pharmacist. Your pharmacists are best known for this, right? They actually know it. What if a patient doesn't report all their drugs at eval? So you get a question on your boards that says, you're treating a patient who has been previously evaluated for X, Y, or Z. The patient reports to you a new medication. What should you do?
Research it.
Okay, research it and tell who?
Tell your
PT.
PT.
Yeah, tell your PT. That's the major thing you're going to see on the boards. It'll say your patient reports now taking an antipsychotic or something to that effect. The goal should be go tell your PT, because that way the PT may need to adjust the plan of care. Minimizing and maximizing safety risks during working with patients, understanding when those medications are at their peaks and when they're at their troughs. Always assume that a patient is on some form of mind-altering medication, including alcohol. It's better to assume they're on a medication that's affecting their brain than to get surprised. And also, don't assume that kids aren't on meds, because kids of late have been on a lot of meds. Right? So please be aware of that. That's it for pharm. I know that was a lot, right? But as far as it goes, safety is the major concern. When you get your questions on your boards, they're specifically going to be asking, you know, what do we do? What do we do with this patient that's on this? Or what do you do with this patient that's on that? And the main goal is protect the safety of the patient. That's it. Right? Keep them safe. Keep them secret. Keep them safe, like Gandalf said. Wait. Oh, he wasn't talking about drugs? Oh, sorry.
Keep it secret. Keep it safe.
Yeah, I know. He wasn't talking about drugs, though. Look, he smoked a lot of weed. Let's just face it. And so do the hobbits. Just look at them. You can tell. They're short and stout. They've definitely got it going on. Anyway, side note. Any questions? Did I fry everyone's brains? Good. That's what I wanted. But the main thing you should take away from it, monitor for orthostatic hypotension, safety, and vitals. That's it. Don't freak out about a poly question. Yep, BP, OH, safety. Good. Those are the main things. And sometimes HR too, right? Heart rate. All right, guys, that's it. I'm done. I'm done rambling.
Can I ask questions?
You may ask questions.
It's not like questions about this. So if everybody wants to leave, it's fine.
You want to stick around and talk to me afterwards? Is that what you said?
Yeah.
Okay. All right, you both can. I see Brooke there. Other than that, you guys are free. It's 1:30. It's 5 o'clock somewhere.
Mm-hmm.
Oh, go ahead, Diana.
You sure?
Yeah, no worries. Mine's like well, I have like 2 questions, so you go ahead.
Okay. Yeah. So, Mr. McKeever, I'm a little bit concerned because the way I feel like I'm not studying enough during the week.
Okay.
I'm working in the morning and I'm studying at night, but I
Okay.
feel like I'm a morning person. Like I like to wake up, like function better at morning than at night.
Okay.
And then I do take advantage of the weekends, but during the week, when I'm working, I don't feel like I'm studying effectively.
Okay.
And I took a test this morning and it hasn't improved since my last one.
Okay.
So I'm kind of like freaking out because I know we have like 4 or 5 weeks left.
Okay.
So I'm having
Anxiety. So you need some anti-anxiety meds.
yeah, right. I feel like when it comes to narrow gate questions, those are like my weakest points. So I was wondering if we could have like a one-on-one.
Sure.
I could
That's
go
what I
to
was just.
team.
That's what I was just going to suggest, actually.
Yeah, like I'll do whatever, but I need
That's
to,
okay.
you know.
Why don't what? So you work in the mornings, you said right now, right?
Yeah, so I work from 8 to 5.
Okay, 8 to 5. Do you want to maybe meet Monday evening after work?
That's perfect.
What time works best for you? What time do you get home?
Over Zoom. We'll meet over Zoom.
Get over Zoom. Yeah, save you having to come in.
We could do like 6 o'clock or 6:30. It's up to you.
Let's do 6:30 because that'll give you time to get back. Because sometimes they've been keeping me till 6 at work. So let's say 6:30.
Okay, that's fine.
We'll schedule that one-on-one then for 6:30. There we go. Done.
And okay, perfect. And then yeah, that's pretty much it. I'm just freaking out. I even considered, because I feel like since I don't know if from here to the test day I improve. I'm hoping I do, but I just think my fallback plan is to kind of maybe reschedule my test.
Okay.
Just
well, we can talk about that.
Okay.
Yeah, let's definitely just sit down and talk about that.
Okay, cool. So Monday is 6:30.
Yep, and I'll send you an invite so that way you have it.
Okay, perfect. And then we'll hit gate, right? And
yeah, we can do whatever you need.
Okay, cool. Thank you so much, Mr. Mercury.
Yep.
Alrighty, bye.
Yep. All right, Miss Brooke, what's up? You're on mute.
Yeah, okay, that's how my day's going so far. I have a question with MOBs.
Okay.
So like for the shoulder versus the ankle, it's
okay.
Opposite rules, right?
What do you mean by opposite rules?
So if you want to improve dorsiflexion, it's going to be a posterior mode. Okay. So you're like, this is your ankle, and then you're going to be pressing here for like dorsiflexion, right?
Mm-hmm. Yep.
It's going to be called a posterior mode. You're going in the direction of posterior.
Yep.
Okay. And then for the shoulder, if you were doing, okay, that's where I get confused.
Okay.
I'm just trying to think. Okay, so if you're doing a posterior mobe, you're actually going to be on the posterior side.
Mm-hmm. Yes. Well, no. So wait. So posterior. So they're named in the direction you're pushing. So
both of the structures.
Uh-huh.
Oh.
Yeah. The main difference that I think I saw something about this, the inverse. I think I want to say PT Finalist said something about that. The main idea about it is that at the shoulder, it gets a little hinky because you have rotation. Yeah. That's why it's not the pure, if you're going in this direction, you go the opposite direction because rotation adds into it. Okay. So a lot of times with the shoulder, you're going to have a posterior and inferior, or posterior and superior mode type idea. Mm-hmm. That's the main idea with the shoulder. That's a little different than like the standard kind of glide joints.
Okay. So my biggest thing is for the shoulder, I just need to know, like, okay, if I'm doing a posterior mobe, it's improving, isn't it? Flexion and internal rotation.
Good. Yep.
Okay. And then,
yeah. So
just know that. And then when it comes to the ankle, I just need to know when you're pressing into posterior, it's going to improve dorsiflexion.
Yeah. The opposite direction. Yep. Exactly. And same thing happens. You're not going to get questions on mobes of the hip very often, but the hip follows the shoulder. So if you know the shoulder, the hip's the same.
Okay. All right.
Does that make sense? So if you've got the hip down that you're saying, okay, if I have this problem with flexion, internal rotation, same thing at the hip.
Okay.
They mirror each other.
Okay. All right.
Like if you're having problems, let's have this. Let's make it a little even weirder. If the patient's having problems with knee extension, because that's a glide joint, which direction are you going to move them in? Think about it logically, though. You're going to move posteriorly.
But I'm going to, it's going to be anterior to posterior?
Yeah, anterior. You're going to go from anterior to posterior. Yep. Yeah. Because you're going to think that'd be the direction of moving them into extension, wouldn't it?
Yeah.
Yeah. Right. So that's where it gets different at the shoulder and the hip, is because I got to refocus my camera here. Is that it's because the hip and the shoulder have the rotational component. Does that make sense?
Yeah, it does. And I saw like a question. It was about for the hip that they wanted to, like, they kind of had restrictions in all planes, I think was the question.
Okay.
And the best one was an inferior caudal glide.
Okay.
So that just gonna completely, you want to put them in the open pack position to do that?
Yep.
Okay.
Yeah.
Okay.
And that's the other major thing about most of the MOB questions is it's going to ask you what position do you mobilize them in. You just have to know the open pack positions. That's going to be the big ones.
Okay. And the big ones to know is shoulder, hip, knee, and ankle.
You got it.
Okay.
That's it. And distraction. There you go. Right, Anthony.
All right. And then I have one question about a test, but
Okay.
I don't want to, if nobody wants to be here to listen to that, because it's not about studying.
Yeah, I mean, I can hang around afterwards. Here, I'm going to strobe my room. There we go. I freak you guys out. No, just kidding.
I don't
All
mind.
right.
I don't mind saying it or whatever.
Okay.
I mean,
What's up?
we can all probably listen to it. Oh, he didn't have to go. So for the PTA final exam,
Mm-hmm.
I took it last week and I got a 54.
Okay.
And there was just some stuff that I was like, okay, I don't even know what that is. So I reviewed it, which makes me feel a little better, because if I didn't know it, then, you know,
Now you do.
now I know now. But where does she want us to be testing there again?
I think she said 65. I think is what she said.
Okay.
Why don't you and I schedule again, like I did with Diana?
Okay.
Excuse me, a little bit of one-on-one session, just maybe to look over that with you,
Okay.
and then we can schedule what works for you.
Honestly, anything.
Okay. So that's right. You're not really working or anything right now, right?
No.
Okay. Do you want to schedule it sometime for Monday? Because Monday's my good day for scheduling because I don't have classes.
Yeah, that's good.
We want to do something like Monday at 10.
Yeah.
Okay.
That works with me.
So let me put that down. Then what I'll do is I'll send you an invite too.
Okay.
And I'll obviously meet you via Zoom, but I'll be at school, so I'll meet you from then. So I'll send you an invite for Monday at 10.
Okay.
That work?
Yeah, that works. I had another, oh my gosh. It wasn't about I was gonna buy my Pete's today. Do you think I should take my first one tomorrow?
If you can, yeah, wouldn't hurt. It
Okay.
definitely wouldn't hurt. I mean, and that's going to give you your most
Accurate. Mhm.
accurate. Yeah, that's what the word I was looking for. My brain was not working there for a second.
It's okay. My brain's fried now too.
Yeah, so that would be your most accurate. Yes.
Okay, because I